अरे आप कहाँ हो डॉक्टर राजेंद्र खन्ना? दिख नहीं रहे।
आ गया।
कब आए?
हाँ अभी आया हूँ।
चलो,
फोन ही होना था यार।
ग्रेट। We are going live in 5 seconds.
हाँ ठीक।
So we are live.
Good afternoon, friends. It gives me immense pleasure to welcome you all to this 5th edition of Delhi Film Festival. It has been a constant feature of wonderful films all across the country and international speakers to provide us with their wonderful and new technique videos where it is very beneficial for the attendees and mainly for the residents who are taking immense benefit from the new techniques shown in the videos. And I always felt that a video is a better way to demonstrate or explain the technique and technology of the surgery as compared to the slide presentation. And that concept went into starting this video Delhi Film Festival. It was conceptualized by Dr. Bhupesh Singh and me together. And in fact, Dr. Bhupesh Singh has been instrumental in starting and giving the back support for doing everything which is there in this video film festival. I thank him for this thought process, and also this time I can tell you, friends, Dr. Bhupesh Singh has been the most active organizer of the two. And I also thank all my sponsors who have done this job wonderfully and to complete complete information regarding this film festival. KLB, Novartis, Cipla, Neomedics, and Allergan, who have given us both manpower and the financial support to run this all across the globe. I will not stand between the next session, which will be chaired by Professor T.J. Pandey and our very senior DOS member and past president, Dr. Rajinder Khanna. And I will invite all my speakers to join. And over to Dr. Rajinder Khanna and Professor Pandey. Thank you.
I have privilege to introduce the learned speakers in this meeting who are not presented so many papers, written, published papers. They have innovative surgeons, they are good teachers, and you have the galaxy of these peoples. You may have to think they are the innovators, so you may have to think about these speakers. I request Dr. Rajinder Khanna to introduce our panelist. Dr. Rajinder Khanna. Am I audible?
Yeah. You can hear you, sir. You can see Dr. Rajendra Khanna, but he is looking a little lost somewhere, trying to search something. Hi, Dr. Rajendra. Hello, Dr. Rajendra Khanna.
So what I'll do is I will introduce our panelists, the esteemed panelists for this session. And we have Dr. Rajendra Prasad, who is the innovator par excellence and is his name goes with the Terminator, whichever way you want to take it, whether it is WWF or WWO, the ophthalmology. Then we have Dr. Gaurav Luthra, Dr. Suresh Pandey, Dr. Rajiv Mirchia, Dr. Harvansh Lal, and Dr. Rajesh Sinha in this session, talking and explaining their videos of their own techniques. So I'll invite the first video, and the speaker and presenter is Dr. Rajendra Prasad. He'll be talking about swing needle microcapsulotomy.
Okay, you can see my screen?
Yes.
All right. Good afternoon, friends and ladies and gentlemen. First of all, I'd like to thank Bharti Eye Hospital, especially Dr. Bhupesh, for including me for this webinar of the Delhi Film Festival, which is one of the, as Dr. Bharti has already told, that one of the very sought after session in ophthalmology, where we learned about the many new techniques and many these experienced surgeons videos in this session. So today's theme is on cataract surgery, and I'm going to talk about Argentinian flag sign. Friends, as you know that Argentinian flag sign is one of the very well-known complications during capsulorhexis in intermittent white and intermittent mature cataracts, where what happens actually, the moment you prick the anterior capsule with the hypodermic sharp-tipped needle, the tear starts extending automatically and uncontrolled manner to the periphery, extending to the periphery and leading to a complete radial tear on the anterior capsule. Now this tear many times extend to the posterior capsule also and lead us into a serious complication of the posterior capsular tear. Now, since this complication is quite serious, a lot of innovations have been taken place to avert and to control the Argentinian flag sign, including the 26 gauge needle aspiration also, which many of us practice. And but despite of so many techniques, we still come across Argentinian flag sign in many of our patients. And if you look at the literature, the incidence of this tear has been reported from 3.85 to 28.3%. And what is more important is, out of these 28.3%, 7 to 24% of the cases, the tear extend into the posterior capsule, so which we consider very serious complication. So today I'm going to show you a video on saving needle microcapsulotomy to avert Argentinian flag sign. This is one of the very simple and very effective and very safe technique. Most important, it's very, very simple technique. A simple saving needle can prevent this complication from getting into a serious complication. So I have this video, which is pre-recorded and with voiceover.
Welcome to RPH Research Center, New Delhi. In this film, we aim to demonstrate an efficient new technique, saving needle microcapsulotomy, to avert Argentinian flag sign during capsulorhexis in patients with intermittent early white mature cataract. The authors have no financial interest in the subject matter of this film. Argentinian flag sign is a well-known complication during capsulorhexis in intermittent white cataracts, which typically arises instantly after an initial prick with a sharp hypodermic needle on a stressed out tense anterior capsule. Till date, it was believed that the raised intraventricular pressure, along with forward thrust of the nucleus, is solely responsible for propagation of the initial prick into a radial capsular tear. To counter this, several techniques, including the small needle aspiration technique, had been described to decompress the bag, but peripheral extension of the capsular tear has still been very frequently seen instantly after pricking the capsule with hypodermic needle, even before the aspiration of the liquid cortex is initiated. It means there had to be some other factors responsible which assist the raised intraventricular pressure to propagate the spreading of capsule after the initial prick. Extensive clinical evaluation, we came to know that in reality, it's not only the raised intraventricular pressure or forward thrust of the nucleus which causes the extension of the tear. There is one more important factor, which is mainly responsible for the extension of the tear, is the configuration of the initial prick created on the anterior capsule. Sharp tip hypodermic needle or Rexis forceps, while puncturing the anterior capsule, always create a linear cut configuration with discontinuous open edges along the plane of the needle bevel. These forms of cataracts have liquefied hyperhydrated swollen lenticular material with an increased intraventricular pressure, relatively makes the anterior capsule dense and stretched out. Tense and stretched out anterior capsule with an optimum intraventricular pressure triggers off a disruptive force along the open edges of the linear cut and help the cut to open up and propagate towards periphery along its margins and split into a complete capsular tear. The disruptive vector forces always act along the axis of the linear cut. That is why the tear always extends radially along the open margins of the cut, but never perpendicular to the linear cut. This confirms that it is the linear cut configuration with open edges which has the potential to spontaneously open up and extend to the periphery. Henceforth, we came up with a hypothesis that if we were able to manually create an opening in the anterior capsule which had a round regular configuration like a capsulotomy in two sense, instead of a linear cut, we may provide resistance against disruptive forces, thus preventing Argentinian flag sign. Round hole microcapsulotomy with round continuous circular edge without any discontinuity do not tear away with the sudden outburst of intraventricular rate and disruptive force generated by the high intraventricular pressure. Simultaneously, of liquefied cortical with the hole decompresses the capsular bag and allows for intraventricular pressure to equilibrate prior to the creation of the capsular axis. To prick the capsule, we developed and designed a novel instrument sieving needle microcapsulotome with like a sieving needle system. The tip is approximately 0.75 millimeter in length, 0.60 millimeter in diameter, and which is angled at 90 degrees to the distal shaft. Sieving needle microcapsulotome, when puncture the anterior capsule, create a round hole opening with smooth margins, unlike the linear cut produced by the sharp needle. In most of the cases, single microcapsulotomy is sufficient to decompress the bag, but in some cases, multiple microcapsulotomies are required to evacuate the multiple fluid pockets in the lens. To achieve successful microcapsulotomy, after routine incisions, the anterior capsule is stained with 0.06% trypan blue dye to enhance the visibility. Ophthalmic viscosurgical device is injected to maintain the deep anterior chamber with appropriate pressure. Using the main or side port corneal incision, the sieving needle microcapsulotome is inserted into the anterior chamber. Tip of the needle is placed vertically over the center of the anterior capsule. For direct visualization, tip is then moved downwards to penetrate through the top anterior capsule. The round pointed tip of the saving needle microcapsule creates a round opening with smooth margins at the center of the entire capsule. Interlenticular fluid gushes out as a volcanic eruption through the hole, which decreases the interlenticular pressure and help in decompression of the capsular bag. Complete evacuation of interlenticular fluid, including the posterior compartment fluid, is achieved by tapping and pressing the interior capsule posteriorly with the help of a air cannula. Once the bag decompression is complete, anterior chamber is decompressed with the help of cohesive visco to pressurize the capsule. An intended 5 to 5.5 millimeter of capsular axis is initiated after tearing the central hole using and easily completed without the risk of peripheral extension of the capsular tear. To conclude, saving needle microcapsulotomy with circular round hole puncture of the interior capsule, along with pressure decompression, is the simplest of techniques, which enables us to successfully prevent Argentinian flag sign with very little effort and much easier surgical maneuvers. Saving needle microcapsulotomy, a simple yet highly effective novel tool, is an ideal device to open up the tense anterior capsule to adequately decompress the bag prior to the initiation of the capsular axis. Initial decompression of capsular bag facilitates safe and controlled creation of a capsular axis of a desired size with higher level of efficiency and safety. Thank you for being with Saving Needle Microcapsulotomy, new technique to prevent Argentinian flag sign and intermittent mature white cataracts.
Thank you very much. So I hope this was the basic mechanics was understandable, and that was my aim. Thank you very much.
Dr. Pandey, you have to unmute yourself.
Nice video, very informative. Good. Keep it up, Rajendra Prasad.
Thank you, sir. Thank you very much.
Is Gaurav with us? Hello, is Gaurav with us? I can see Dr. Pandey. I think Dr. Pandey can start if Gaurav is not with us at the moment.
Gaurav is not with us at the moment.
Dr. Pandey.
Yes, yes, sir. Good afternoon. Can you hear me? Am I audible?
Yeah.
Good afternoon. First of all, I would like to thank Dr. Bharti and the team Bharti Eye Foundation for this wonderful Delhi Film Festival. And today I'm going to present a video about the Zepto precision pulse technology. And I'm going to share some of the difficult cases with this technique. So can you see my screen?
Yes.
Yes. So as we all know that the capsular axis is one of the most important steps of the cataract surgery. And now we have the femtosecond laser and different tools to achieve the capsular axis. Zepto precision pulse technology is one of the most innovative device. Just a minute. There is some problem.
Dr. Pandey, can I help?
Yes, there is some problem.
Yeah, no, it's okay. Just first open the presentation,
Okay.
the background, then come back to the Zoom window and then share.
Okay, okay.
Just open the presentation and put it on pause.
Okay, okay.
In the meantime, I want to inform the audience that Dr. Gaurav Luthra will be presenting in the last of this session. And instead of Dr. Rohit Om Prakash, in this session, we will have Dr. Rajesh Sinha presenting his video. Yeah, Dr. Pandey, can you share your screen with the video?
Yes, yes. I'm just taking 1 minute to share my screen. I will just exit and I will share a screen. Here is a screen, and then I'll just
I think he's exited, sir.
Maybe meanwhile, someone else can.
Go ahead with the next.
Sir, you are mute. Dr. Bharti, sir, you are mute.
Dr. Bharti, up mute.
You are mute.
Yeah. So,
Yeah.
Till Dr. Suresh Pandey gets his video sorted out and gets to know how to share his screen, I would request Dr. Rajesh Sinha to present his video. I think he's ready and he can go forward and present his presentation.
Okay. Thank you, sir, for the opportunity, and thank you for allowing me to present in this session because you accommodated me in this session. That's really nice of you because I had some issues yet for tomorrow. So I'll be presenting a case wherein there was an intralenticular foreign body. So I felt it was something which we all should discuss about and maybe convey some message about it, how to handle it. So that's why I thought, let me present this video. You can see here, this foreign body has gone from this side, from here, it has made an iris hole and then has entered inside. So I'll start the video and show you the steps, what all has been done. Now, I'm sorry, I have not been able to show you the KZIA picture, wherein it showed that the foreign body was close to the posterior capsule, but it was not, it had not perforated the posterior capsule. So after entering the anterior chamber, intracameral adrenaline was injected. And then, as you can see here, this is the capsule which is damaged. And this is the foreign body, iron foreign body that has gone inside. So the idea is that we have to do a capsular exis since it is at such a point that we cannot include this part into the capsular exis. So the rexis should be inside this opening, which is a scarred opening. So that is what I have planned, and you can see the opening here. The foreign body has gone through this opening in the capsule, and the capsular exis is just anterior to that. So that is the aim. The second thing is that I don't want to do too much of manipulation and too much of pressurization inside the lens. Otherwise, the foreign body can migrate and can push the posterior capsule. So just a very gentle hydrodelineation, no hydrodissection was done, so that there is no movement of the foreign body, it remains there. And then the idea was to debulk the central part so that I can create space in front of the foreign body and then hold the foreign body with forceps. The basic idea was not to damage the posterior capsule and not to get the foreign body to migrate. So you can see this is a sharp metallic foreign body, which was impacted in the lens. So once it was held, it was taken out, and you can see here, this is the sharp edge. This is the point through which it has entered. And then once it was taken out, then the lens fiber was aspirated out. And you just have to be, even if you see the picture on OCT or on KCR, you still have to be a little careful that, whether there's any touch into the posterior capsule is there or not with the foreign body, because it was a sharp foreign body. So as you can see here, the whole cortical fiber is out. The posterior capsule is absolutely fine and intact. This is the anterior capsular opening and the fibrosis around that. The idea of doing capsular exis was anterior to it, so that everything goes in a controlled manner, including the capsular exis as well as the location of the foreign body. And this is the opening, which I'm trying to show. And then once this was done, it was like any other case. In the bag, IOL was implanted inside the bag. And take it off. Yeah, the IOL is implanted in the bag. The viscoelastic is being aspirated from behind the intraocular lens. And once you have aspirated it completely from behind the lens, then you come forward, remove the viscoelastic anterior to it. So the basic idea of presenting this case was to see to it that, first of all, you should evaluate that if there's a foreign body that has gone inside, then whether it has damaged the capsule, how much it has damaged the anterior capsule, how much it has damaged the posterior capsule. All these things have to be evaluated. When the foreign body is inside the lens, so you should try to see that the foreign body does not move while doing your manipulation. So that is why just the anterior debulking was done, and then the foreign body was held with the forceps. Now here there is one point that I would like to mention, that why there can be another thought that maybe just after doing capsular exis, one can go in and try to hold it. But the problem is this, that if you have not debulked the anterior nucleus and you have not created space, then you may even push the foreign body, and that can damage the posterior capsule. That was the reason why I wanted to debulk the nucleus, remove it, so that I could create a space and then hold the foreign body nicely and steadily, and then it was taken out. Thank you very much.
Thank you, Professor Sinha. A wonderful video to show how you can gently maneuver the foreign body out without damaging the endothelium or the posterior capsule. Though when I talk about this, go ahead.
See, once it was held, then the flat surface, you could see that the flat surface was taken up. So, and then it was taken out from the 2.2 millimeter incision. So the incision was bigger than the foreign body. So there was no issue. Only thing is that the flat surface should be facing anteriorly and posteriorly, so that it can come easily through the corneal wound.
Rajesh, how do you make sure
what
that
I wanted to comment here was about 15-20 years ago, there was a video by Bobby Osher in ASCRS, and there was it was early days of phacoemulsification, and everybody was worried about the nuclear fragments damaging the posterior capsule and causing PC rent. And what he showed at that point in time, he took out couple of pebbles, not the round pebbles, but sharp pebbles from the street, autoclaved them and put one by one 5 pebbles in the capsular bag, and showed that even when they are heavier and pretty decently sharp, they still will not damage a posterior capsule unless they are moving, like in this Dr. Sinha's case, where there was a lot of energy in the sharp foreign body. So this is what it is. Even if you maneuver, or the movement of the fragments, so the nuclear fragments will not cause a, unless you are very harsh or not very gentle with handling of that. So the posterior capsule is reasonably rigid against getting torn in this case. But wonderful video, Professor Shina, wonderful, absolutely.
Thank you, sir.
Rajesh, how did you make sure that the posterior capsule was still intact in this particular case? Was OCT was?
Yes. That's what I told, that I couldn't show you the KCA clip. I had thought of taking it today, but I just forgot. So I could show that KCA clip, which was showing that the posterior capsule was not damaged. So I was sure that the posterior capsule was not damaged. Now, my only concern was that the foreign body should not move while I am maneuvering. And that's why I just did a gentle hydrodelineation and no hydrodissection. So the central nucleus was only delineated, it was taken out, so I could debulk and empty the interior part of the lens, through which I can go and grasp the foreign body and take it out. So I didn't do anything to the epinucleus, I didn't do anything to the cortex, so that the foreign body remains there in the epinucleus, impacted and in the same position.
What would have been your approach if, say, the posterior capsule also made the nick on the posterior capsule by this foreign body?
See, if there was a nick in the foreign body, I may like to wait a little longer, so that I'm absolutely sure that that area along it has been fibrosed. Okay, so once it is fibrosed, once again, what we can do is that we can just do a gentle hydrodelineation, try to debulk the central part only, so that we can hold it. But if it has damaged the posterior capsule, a little longer waiting time is I think required, so that the margins that have been damaged, the posterior capsular damage, the margin of the damage should be fibrosed nicely, so that it doesn't move much. So
thank you.
Body will remain
forward, and I would request Dr. Suresh Pandey to present his video, please. Thank you, RP.
Okay.
Are you ready?
Sure. Good afternoon.
Sir, it is Dr. Pandey.
Yes, I'm just trying to share my screen.
Just stop share for a minute, sir. Stop.
Yeah. Can you see the screen now?
No, sir. No, sir. It won't.
I can see the screen. Yeah.
Dr. Pandey, what you do is you just open it in, say, VLC or whatever, and just pause it, and then you can share it, because when you are sharing the file, you will not be able to open it when you are sharing it. So you have to open it before you share.
Okay.
Hi, Gaurav.
Hi, Rajesh.
Yes.
Hi, Dr. Bharti.
Hi, Gaurav.
Everybody.
Hi, Dr. Gaurav.
Hi, Dr. Suresh, Dr. Mitchia.
Hi. Hello.
I'm sorry I joined late. There was some confusion. I didn't realize that how the session is today.
You're not too late.
सुरेश, इसको पहले इस स्क्रीन को मिनिमाइज कर दो.
Dr. Harbans, Dr. Rajendra Prasad, Dr. Khanna, Dr. Pandey.
सुरेश,
everybody is there.
इसको मिनिमाइज कर दो, ये लाइव स्क्रीनिंग को पहले, फिर अपने फाइल खोलो.
As we go forward, in the meantime, you can talk to
share करो आप.
on the telephone, RP. you talk to Suresh Pandey on telephone and instruct him. In the meantime, can I request Dr. Rajiv Mitchia to start sharing his video?
Yes. Can you see the video now?
Okay.
You can see it.
Here you are.
Perfect, sir.
Okay. Okay. So I'm sorry for the some technical problem. As we were discussing that the capsular axis remains one of the most important step in the cataract surgery, and today I'm going to talk about the JETO precision nanopulse technology to manage some of the difficult cases which we have done using this technique. So JETO precision nanopulse technology is an innovative disposable device for the cataract surgery, and it works on the principle of precision pulse technology, which produces the accurate, reproducible capsulotomy that is quick, safe, and reliable. And the device consists of the handpiece and the nitronol ring and the suction cup, as you can see beautifully in this video. And the nitronol ring is the one of the most important part of this device, and the suction cup consists of the silicon suction cup, and the thermal temperature control study has shown that there is not much significant increase in the temperature while doing the capsulorhexis with the precision nanopulse technology. The Miyake-Apple studies has shown that this device can produce the capsulorhexis without causing much stress on the zonules. And the one of the most interesting part of this device is that this can produce the capsulorhexis very quickly, and there is a complete capsulorhexis without any tags and any irregularities. And the study has also been done in the cadaver eyes, and before introducing this device into the human eyes. And the device is consists of the handle, which is similar to the vitrectomy cutter handle, and this can be retracted, and once you enter inside the antechamber, the device can open up, and with the using the vacuum you can hold the antecapsule, and once you push the button, then you can have the capsulorhexis very fast. Before starting the capsulorhexis, you need to prime the device. One of the limitation of this device is that this is the disposable device, so this adds some extra cost to the surgeon. The cost of the disposable device is somewhere around 6,000 rupees. So this is an extra cost to the surgeon. So this is a limitation. Once the cost will be reduced, then perhaps more and more surgeons can use this device for managing difficult cases. And once you prime this device, after priming the device, you can just you can just do some initial setting, and then introduce the device using 2.8 millimeter incision. Now they have device which can go with the 2.2 millimeters also. So once you create a suction, and then you can use the power, and within few seconds you can see the bubbles are moving, and this indicates there is a suction, and the device is tightly holding the entire capsule, and within few seconds this can create the capsulorhexis. So I will be showing a few interesting cases. So this first case is 36-year-old lawyer which came to us with the intumescent cataract, and he was very keen for getting the premium lens implantation and without or with minimal dependence on glasses. So once we stained the capsule under an air bubble, and using the dispersive viscoelastic, and the device was primed, and the JETO handpiece was inserted into the anterior chamber, and then the vacuum was applied, and then you can see once the power was applied, within few seconds you can see the beautiful creation of the capsulorhexis, which is approximately 5.2 millimeter in size. And notice the capsular flap is complete without any tags. And once the capsulorhexis is being done in such cases, then remaining steps are straightforward, and you can aspirate or you can do phacoemulsification in such cases. without any risk of Argentinian flag sign. So this is the case of Zeptocapsularexis, and then this was followed by implantation of trifocal lens in the capsular bag. And after trifocal lens implantation, the patient regained excellent near distance and intermediate vision. So the case this case Zeptocapsularexis or Zepto device was very helpful to produce a uniform well-centered capsularexis in this case. And we always use intracameral moxifloxacin and triamcinolone in our practice, and to minimize the first post-step there, the patient regained good vision, and the vision was 6.6 and N6. So this was the first case of the mature cataract, and the second case was the hypermature Morgellon cataract with the corneal astigmatism of 2 diopter. So where we used the toric multifocal lens. So you can see the marking was done, the slit lamp axis marking, and the marking was done, and then we made incision. Staining was done under an air bubble, and then Rexis was done using the precision nanopulse technology, using a Zepto handpiece inside the anterior chamber. And notice the handpiece is being inserted, and this was positioned very well. And you can use the handpiece irrespective of the pupil size, and irrespective of the corneal, if there is some localized corneal opacity, then also you can use this handpiece. And notice the cortical milk is being, is there once the Rexis was done with the Zeptorexis device. And this is the complete capsular flap, and you can see the, and then phacoemulsification was done with the implantation of toric multifocal lens in this case. So this was second case where the capsularexis was done with the precision nanopulse technology, and this was followed by implantation of the toric multifocal lens. And the third case was case of small pupil, and here I'm going to show you that how this device can be useful in cases of when pupil is not fully dilated. So this was a small pupil case. Perhaps he was due to floppy iris syndrome. He was under tamsulosin hydrochloride since some time, and the Zepto handpiece was primed and then inserted inside the carefully inserted beneath the iris, and just make sure that that it just there is a good alignment. And once you apply the suction and the power, then you can see the beautiful capsular axis. And after doing capsular axis, you can manage the small pupil case. You can use the malignant ring also based on your experience and your the need. So this is the third case. So in summary, Zepto precision nanopulse technology is helpful to manage white cataract cases, to minimize the incidence of the Argentinian flag sign. And one of the limitations of this device that you need to insert inside the anterior chamber, and so that you should be careful while inserting this device into the shallow anterior chamber, or in cases where there is a corneal endothelial cell count is less. I always insert this device after using viscoelastic such as Viscoat or chondroitin sulfate based viscoelastic, and we should not use this device in cases of very shallow chamber with poor endothelial cell loss, because inserting this device inside the anterior chamber can produce some endothelial cell trauma. And the theoretical complication can occur, for example, failure of to achieve the complete capsularexis, or inability to open the device. But I have not seen any complication in my practice. I have done approximately 50 cases so far, and this was our initial 3 cases which we have published in Indian Journal of Ophthalmology. Thank you so much for your kind attention.
Thank you, Dr. Pandey. It was excellent to see the nanopulse technology in anterior capsulotomy. But the problem sometimes, if you put the viscoelastic and the Zepto, so what is the reaction in anterior segment? Do you have any problem with the iris?
Actually, sometime you have seen that, if the pupil is not dilated, then once you apply the vacuum, the pupil can become further smaller, as you have seen in the last case. So perhaps this device works very well when you use you use not too much viscoelastic, because sometimes if there is too much viscoelastic, there can be inability to build the vacuum, and then you can get some problem with the vacuum, and therefore inability to achieve a complete capsular axis. So you need there is some learning curve in initial few cases. It requires that you once you get used to it, then you can achieve consistent result.
Is,
Dr. Gaurav can also share his experience. He is also using it.
Can I say something?
Yes.
Can I say something?
Yes.
Yeah, I feel that with the Jepto also, the chances of incomplete rexes are there, rexes margin tear. So doing in a mature cataract without seeing, and then you're not so sure whether the rexis is complete or not, maybe at times may prove a little dangerous. And secondly, we can all perform phaco through a small pupil, but I think you cause more iris damage in the subincisional area when you do not have any dilating method over there. So using Malugin ring will damage less iris sphincter than trying to keep on rubbing the iris in the subincisional area while you are trying to take out the cataract. As in this case also, there's some chafing of the iris in the subincisional area. So when
That's very good point, Dr. Harbanslal. You have mentioned very good point. I think with a small people, better to use Malagin ring, and then you achieve after using the Malagin ring, then you you can achieve complete capsuloxis with any device, or with manually.
Jepto is excellent.
Yeah.
So
I
very
use
important.
Malugin before using Zepto.
In all my mature cataract, whether patient pays or not, I really don't want to put myself under pressure and tension. I use the Jepto. But you told the price is 6,000, but we are getting it for 13,000. Are you getting it for 6,000 rupees?
I think it's 8,000 rupees. Price is I think it's 8,000 rupees the hand piece.
Bharti, how much you are paying for it?
And
the machine is 10 lakhs rupees, I think 10 or 11 lakhs rupees. But
and piece is for 10,000. So when it started coming about 3-4 years back, it was 10,000. Yeah. I don't know now because I'm not using much of it now.
Yeah,
3-4 years back
only. They are charging 13,000 something now from us.
10,000 and I think 10 plus 2.
12,000.
No, 10 plus 2 is
we go forward, please, because we are running short of time, and I would request Dr. Rajiv Mirchia to start sharing his screen and video.
Sure, sir. 1 second. Good evening, ladies and gentlemen. I would like to thank Dr. Bharti and Rupesh especially for allowing us to run this session. See, my topic for the day is lax and posterior ICL cataract. We do so many ICL nowadays, and we all have to face this problem of facing the cataracts one or the other day. This was a 31 years old male NRI who presented with post ICL cataract. The STAR ICL was done 6 years back. He wanted a multifocal lens. The IL power comes out to be +4 diopters, so we planned a customized Indian multifocal lens. The biometry was +4. I'll start with the femto cataract.
Oh.
1 second, sir. I'm not able to start my video.
So the video is in second slide. So next slide.
Oh, okay. No, that's for the surgery part. This was for the femto.
Just put in the presentation mode, sir. एक बार presentation mode में डाल दीजिएगा screen से.
How do we do that?
और press F5. F5 function बटन है F5.
F1.
F5.
F5.
Sir,
Rajiv,
ऊपर
if you go on the bottom right corner,
जी
you
Yeah.
have a small video. Here,
सर,
if you
नीचे
can-
माइनस के स्लाइडर जहाँ पे माइनस है उसके नीचे, हाँ उसके बगल में वाला जो आइकन है यहाँ,
Yes.
ये वाला?
हाँ जी,
Yes, yes.
Yeah.
परफेक्ट सर.
So we had to adjust for all the parameters, including the anterior and the posterior capsule, because it was not like the routine cataract. The shadow of the ICL was also in between, but it was absolutely easy to maneuver and adjust all the parameters. As you have seen that we are adjusting the posterior capsule with these three icons. Yeah. So the capsulotomy is complete, the division. The main port. And the side port. The femtolaser part was complete. And the surgery part, the ICL was grabbed, assisted by the side port, and we could just bring it out. The capsulotomy was not a free-floating capsulotomy, but some small attachments which we could easily maneuver with a small cystotome. A hydrodissection was done, and it was a very, very soft cataract, just 31 years old male. And a simple aspiration was enough to remove the whole cataract. We cleaned the undersurface and some polishing was done with the I8 tip itself. But despite that, The post-operative outcome was very satisfying. Third post-operative day, he had uncorrected vision of 6/6 N6. Patient came back to India for a follow-up after 1 year with a decreased visual acuity. He had been calling us up from there that he has some problem. He was diagnosed with PCO and post-YAG capsulotomy. The vision was 6/6 N6 again. Thank you so much.
Thank you, Dr. Mircha. It was very excellent presentation. You come out
Thank you, sir.
very nicely with Dr. Harvinder, who is going to next?
I'm going to do that.
Speaker, Dr. Bharti. Okay.
Can you see my screen?
Hello, friends. I'm Dr. Harvinder. Can you see? Daily IC.
All good, sir. All good, sir.
And Chairman, Department of Ophthalmology.
Yeah. We're able to see it.
Today, I'm going to talk about how not and how to operate the heart cataract. When we are operating heart cataract, there are certain anatomical facts to be kept in mind. Central part of the nucleus is densest and thickest. Its concave backwards and its fibers are so to split and chop the nucleus successfully, need to make deep central trench. Now watch the video. In this video, a nice good exercise has been achieved. Hydrodissection is being performed to rotate the nucleus, and once it is done, we start making trench into the nucleus. We are going to do stop and chop technique. And as you can watch now, we are trying to widen the trench, but are not able to do so very easily. And we try to deepen the trench in the center. We are not able to deepen the trench in the center because the sleeve is much wider than the tip, and sleeve does not allow you to go into the center. So now we will rotate the nucleus and try to train the central part of the nucleus. Very far, central part already well trenched. Again, you can see that the sleeve is obstructing us go deeper into the central part. With the result, our central trench is little shallower than usual. We are again trying to widen the trench so that we can reach the center and hardest part. Otherwise, this trench is good enough. Considering this cataract is very hard. Central part is hardest and thickest. The trench was not deep enough. And when we try to split it, we get the peripheral split, but are unable to get the central split. Now we are trying to chop it. You can see that the grip is little superficial. It is not the deepest and densest part of the nucleus. With the result, only superficial fibers are the actual nucleus separated. To highlight further, I will like over here basic and only mistake the surgeon did was not making a wide enough trench in the beginning. Now I'm going to talk about how to operate the heart cataract by my technique of V-arbitrary trench and radial split, or you can also call beam split. Now you watch, I'm not making this trench in the center, but I'm making paracentral trench in a shape of V. Do not try to bite much of the tissue in each pass. Just keep on shaving slowly and slowly, more in the central part than at the peripheral part. Once you reach to the center, your strokes are much smaller in length. The shape which is created now is V, much wider at the periphery. Now we have withdrawn and we inject the viscoelastic before drying the phaco tip. We are going to do the hydrodissection now. We will not do the hydrodelineation. Not doing hydrodissection stabilizes and keeps the nucleus very steady while trenching. and most of the trench has been created. Now we rotate the nucleus and now see the wider peripheral part will be able to accommodate the sleeve much more easily, and we will be able to reach to the depth of the central part of the nucleus much more comfortably. Once your trench is deep enough, we try to crack it and watch that the crack is complete in the center and peripheral both, but there is a plate of posterior leathery fiber which is not allowing a nucleus to be divided into two. So how to proceed further to divide this? So I'll be showing my technique of radial split. Now we will hold one end of the heminucleus with a very high vacuum setting of 600 and start moving the another heminucleus radially, splitting the leathery fibers up to the center of the nucleus. See how beautifully they get split. Now we will rotate it and repeat the procedure at the another end. And the important point is hold the nucleus at the periphery, not at the center. Have a very high vacuum setting and rotate it radially. It is like the beam has splitted the thighs of the Duryodhana. The key point in operating the hard cataract is deep trench initially. Once you get a good split and can break the nucleus into two, the rest of the surgery is very simple and very comfortable. And the best part is that phaco energy used for making trends causes no collateral damage. Thanks for watching. So thank you very much for watching.
This was initially what you propagated as victory cut.
Yeah, you are right. Actually, now
we learned a lot of things from this.
Yeah, actually, I don't do hydrodissection in these because the nucleus sometimes starts rotating and trenching becomes very difficult. So in this, you will see that there is no pressure on the gnues, there is no stress, just very slowly. I mean, this is a technique for any beginner and with any machine can do. Of course, Rajendra Prasad has got excellent.
Absolutely correct. Because very hard nucleuses are very difficult to rotate unless hydrodissection. Bharti,
I am all set to start my video whenever you say.
Please welcome.
Sorry?
Welcome. Please start, sir.
Yeah. A small posterior capsule defect without disturbance to vitreous can be converted to a posterior continuous curvilinear capsular axis using a specially designed forceps which can enter through a side port without disturbing the antechamber, causing shallowing of the antechamber. Antechamber is filled with dispersive viscoelastic and capsular axis is grasped repeatedly, and a small increment in rexus size are done to provide good control on its size and shape. A dispersive viscoelastic is injected into the bag between anterior and posterior capsular axis. It is ascertained that the posterior capsule remains concave and there is no shallowing of the antechamber leading to vitreous upthirst. A single piece IOL is injected and gently maneuvered into the bag. Here is an interesting case of femtolaser cataract surgery. The main port is opened and visco injected to reveal a free-floating capsulotomy. A routine maneuver in the nucleus is done with the default phaco settings when a posterior capsule defect is recognized. This is presumably caused by the laser cutting deep into the posterior capsule. Now, special care is taken that the vacuum buildup is minimal during the cortical removal. Aspiration is done away from posterior capsule, and corticocapsular adhesions are broken gently with special care taken not to hydrate the vitreous. The posterior capsule defect is now exposed and visible clearly. The gentle aspiration of the cortical material is done, taking care that the capsulotomy tags are not pulled into the aspiration needle. Gently, all the cortical material is aspirated. Special care taken not to leave any cortical matter behind that may cause a sterile reaction at a later point in time. A dispersive viscoelastic is injected, inflating the bag slightly. A single piece IOL is injected, allowed to unfold itself in the anterior chamber. And gently slided into the bag without disturbing the posterior capsule and vitreous. Here, it shows that early detection of posterior capsule defect and gentle maneuvering during these steps will not increase the posterior capsule defect. In a large posterior capsule defect, as in this case, a structured disciplined approach is required to be implemented in these challenging situations. Maximum cortical matter is removed by aspiration. The retained cortical matter is the main cause of subacute chronic endophthalmitis and should be removed as much as possible. Special care is taken not to hydrate the vitreous, thereby causing intraoperative rise in intraocular pressure. Vitreous incarceration in the incisions can cause retinal breaks, detachment of retina, and endophthalmitis. The vitreous is removed from the anterior chamber by anterior vitrectomy. The vitreous cutter is also inserted into the anterior vitreous cavity to pull residual vitreous posteriorly. A thorough anterior vitrectomy is performed to remove vitreous completely from the anterior and from the incision. A specially formulated preservative-free triamcinolone acetate is injected from the side port into the anterior chamber to identify the vitreous. PSS solution is injected through the side port to wash the triamcinolone and show the vitreous tags clearly. The triamcinolone has an additional anti-inflammatory benefit during post-operative period. Anterior vitrectomy is repeated to remove the vitreous tags stained by the triamcinolone completely. The eye is examined to make sure that there are no vitreous tracts remaining in the anterior chamber or in the incisions. dispersive viscoelastic is injected into the anterior chamber. A 3-piece intraocular lens is inserted and placed into the sulcus. It is dialed in front of the capsular axis. The optic capture is done with the anterior capsular axis. The viscoelastic is removed from in front and behind the intraocular lens. This way, the dispersive viscoelastic is removed from the eye as much as possible, thereby reducing the chances of sterile inflammatory response. Pilocarpine is injected to constrict the pupil and to recognize the vitreous tags, if any. And then the AC wash is done again to remove the pilocarpine. Posterior capsule rupture can happen in hands of any surgeon. A planned approach is likely to get better outcomes without long-term complications. A dispersive viscoelastic is better since it is not sucked en masse and more often absorbed through trabecular meshwork, causing lesser incidence of raised IOP. Vitrectomy may not be required if vitreous remains undisturbed despite the size of posterior capsular rupture. Vitreous incarcerated in this section leads to retinal tears, retinal detachment, and endophthalmitis. An anterior vitrectomy is better for anterior segment surgery, along with staining of vitreous with triamcinolone for better visualization and complete removal from anterior chamber and caudal sections. Thank you very much, friends, for watching this.
Thank you, Dr. Bharti, the excellent presentation and the various type of the posterior capsule rupture, how to manage, how to use the viscoelastic and how to remove the vitreous tags from the anterior chamber for the anterior segment surgeons. It's a very nice presentation. One or two things I want to know, and some of the audience also they want to know, how do you recognize the PCR during your cataract surgery, number one. Number two, how you manage the earliest sign of the, this PCR, and then how they recognize and how to manage. These are few tips to the persons who are listening in our meeting.
I think the most important thing to observe are two, and one is the pupil snap sign, and the second will be the immediate deepening of the anterior chamber if there's a PC rent. So the couple of things together, they indicate that there's a PC rent, and you have to be very cautious because both these signs are very subtle signs and you may miss them if you are in a hurry. So those two things are very important, and as soon as you observe, you start going very gentle and slow.
Okay. Do we have the next speaker, Dr. Rohit Om Prakash, Dr. Saurabh Luthra, who is going to speak?
Sir, next speaker is Dr. Gaurav Luthra.
Okay.
Thank you, sir. I'll start sharing my screen, sir. One moment, so I think there's a, I'll have to just close one of the screens, otherwise they're trying to show me two screens.
Yes, Dr. Gaurav.
Yes, sir. I'm just sharing my screen. One moment.
Okay.
I'm asking for some permission to share. There is some problem. I'm sorry. Okay, one moment. So hopefully it'll allow me to share. Now it's asking for some. Okay, got it. Yes. So I think is my screen visible, sir? Is my screen visible, sir?
Yes, sir. Yes, it is visible.
Okay, great. Thank you, sir. So I'll be talking about this small topic, which is very important, but a very small little thing on how to minimize chamber fluctuations using some small little instrumentation tips and innovations without spending a fortune on buying a big machine which controls fluidics like the Centurion or maybe the Signature Pro, which are very, very advanced machines which are now able to manage chamber fluctuations even with when you are, it's like a no-brainer. But every surgeon may not be able to afford to buy some of these top-end machines. So chamber stability has been very important, and I'll come to the videos after one slide. Chamber stability, as you all understand, has been one of the key things right from the beginning with phaco machine dynamics, starting from the time when we started operating. I remember in 1998 buying a Storz Protigi with a Venturi system, and everybody warned me that it will be a very difficult machine to control, and you are going to have problem with surge because it's a very fast machine. Frankly, of course, all these things didn't worry. Didn't happen too much, and you can always control surge, and you can have good chamber stability with, surgeons at that time used to propagate putting the bottle height right to the roof, or using a fish pump to ensure high pressure fluidics, and lots of things were tried at that time for doing high vacuum phaco. And however, the surge usually happens because of either high vacuum settings or fluid losses from the ports which are unaccounted for, and newer machines are able to have settings which can account for these fluid losses and compensate for them, like the Centurion and even the Signature Pro. You can operate at very low bottle heights. So we all understand that when there's a surge, there can be complications. You can have a PCR, you can have high risk prolapse, and so many other damages, including zonular days. And so best thing would be to somehow avoid them. Now, I wanted to share, I feel that making the right incisions is probably the key things to minimizing fluid losses. So while we all have learned so many arts of managing the settings of the phaco machines, using better and better machines and everything, however, we still probably don't pay as much attention to our incisions. Now, of course, incisions can be, you have to have the right instrumentation, very sharp new knives. And if we continue to use used knives or autoclave knives or ETO knives, you will always have incisions which will be difficult to make, and they will not be perfect. Even femto incisions, for that matter, may not be as good and as well sealing as you might want them to be. And it is very important to have excellent quality keratomes. And you can see that you don't even have to stabilize the eye when you're using a good keratome. The keratome will go automatically through that, and you can get a good incision. However, just having good keratomes is probably not the answer. And you can actually, if you have a leaky incision, for example, for the main port or for the side port, you will obviously have situations where the fluid losses will still be there. So the main port we have all paid a lot of attention to, and we ensure that we have the perfect size keratome so that the phaco sleeve and the phaco tip goes in nicely. But very few of us actually pay attention to the side ports, and you can see here that my side port is leaking away. And obviously this fluid loss which is happening continuously will not allow me to have a stable chamber, because whenever there is suction loss from the, whenever there is occlusion loss at the phaco tip, there will obviously be a sudden surge, even though I'm using a Centurion, which will compensate for it. But frankly, if you're working on high settings, you may still get a surge. So, I experimented by using this chopper, which is a special chopper designed by Epsilon, where, the shaft is a little wider and it tends to, occlude the incision. However, you can see that in spite of that, my incision being a 21 gauge or 20 gauge incision, it is still leaking continuously. So while my bimanual IA is matched to my incision, so I will not have much fluid loss and a more stable chamber. But during chopping, where the critical time is when your phaco handpiece is inside the eye, you are more likely to get surge because the chopper port will continue to leak fluid, and you will have issues over there. So what's the answer? Going on, if you use an instrument like this, which is, I don't think this is going to play. Okay, it is. So if you use a blade like this to make the incision, obviously your incision size cannot be controlled at all. I use an MPR for I think maybe for the last 20 years, but many surgeons obviously like to use this instrument, and I often wonder that how they control the size of their incision, because the more you push the knife in, the wider the incision is going to be, and you cannot calibrate it. So we started working on trying out different knives for calibrating our incision sizes, and we went to 21 or 22 gauge, and with the help of Epsilon, I was able to get some special bimanual instruments designed and special choppers designed, which match the instrument size. And here you can see that we are trying to use a smaller gauge blade over there to make the incision. And of course, your main port has to be of the right size. And here you can see the special chopper which I'm using, which is kind of little dilated. It's a much wider shaft than you would have on a normal chopper. So it is actually able to occlude my incision. This is a 22 gauge incision, which the chopper is completely occluding. So there are almost no fluid losses here. And if you can appreciate that we are working at a bottle height of just 40 centimeters on a Signature Pro machine. And of course, the fluidics are excellent, but also that, even with a very hard cataract, you will not have much surge or fluctuations, because you're ensuring that there are no unexpected fluid losses or unaccounted for fluid losses from the main port or from the side port. And this gives you a very, very stable chamber, and it minimizes the fluctuations in the chamber, even when you're working with very hard cataracts. And you can see that the incisions are fairly tight, because I'm having to struggle a little bit with putting my bimanual eyes, which are also matched, and these are also specially designed by Epsilon for me. And you can see that both of them are sandblasted in a very, very fine way. So I can actually polish with either of my hand pieces, but this is not a very, very coarse kind of a sandblasting. It is basically a minimal, but these are high flow infusion sets, and the inner bore is very, very thick, and the walls are very thin. So these are specially designed bimanual eyes, which are able to give us a fairly good flow as well. So I think if you're matching your instrumentation to your instruments, it makes a lot of difference. And sometimes if you're not able to do that, you can go on to making different size incisions. So here I just wanted to share before I finish, my main port, one of my side ports is of the regular 21 gauge, but for the second one, if you'll notice, I'm using a 23 gauge. This is when I was experimenting with different instruments. So this is a very, very fine 23 gauge MVR, which are all available. I'm using money knives, which I have no financial interest, but I think they come in all sizes from 20, 21, 22, 23. So you can actually choose what you want to use. So here I will be able to use my chopper, which is also again now matched to the 23 gauge side port. And I'm able to complete my surgery at low bottle heights and with minimizing surges over there. So I think this helps me. And now if you'll notice that at this point, I will enlarge the 23 gauge to now a 22 gauge. And I can now have my bimanual IAs, which are 22 gauge, and they can give me excellent sealed incisions, minimizing the possibility of surge and therefore complications associated with that. So my take home message from this is that for all phaco surgeons, I think chamber stability is of the utmost importance, and the predictability of the surgery depends a lot on ensuring a safe surgery by making perfect incisions and making the right size and shape, and using the right instrumentation for the incisions can make or break a perfect surgery. So calibrating the side ports can be a great way to minimize chamber fluctuations and replicate the fluidics of high-end machines, even with very basic machines. So I've realized that when I go for live surgery, even if I have a very ordinary machine which does not have those fluidics, I can still get away by making sure that my incisions and all are matched to my instruments. And I think that's what my take-home message is. Thank you so much.
Thank you very much, Dr. Gaurav. It is very excellent. Definitely in the phaco, chamber stability is utmost important for the successful result. And this is very good. I have shown the different size of the keratome or different size of the ports, which can be sealed by the different type of the instrument. Definitely it will help in managing the stability of the chamber. Thank you very much. Is Dr. Rohitam Prakash is here? Are any question?
And I would like to thank Dr. Bharti for inviting me for today's session. Thank you so much, sir. This is a landmark session, and it's great to meet up everybody on this.
Gaurav, you are
Thank you, everyone. Thank you. Nice session. I think the next session, the
Thank you,
people
sir.
of the next session are waiting.
Yeah, but
Yes.
in the meantime, we have to honor Novartis with the video because they have supported us in this endeavor of ours. So there's a small video of Novartis for 2 minutes.
Elevro suspension is administered once daily beginning 1 day prior to surgery through 14 days post-surgery, with an additional drop administered 30 to 120 minutes prior to surgery. Elevro suspension is contraindicated in patients with previously demonstrated hypersensitivity to any of the ingredients in the formula or to other NSAIDs. Use more than 1 day prior to surgery or use beyond 14 days post-surgery may increase patient risk and severity of corneal adverse events. The medication enters the cornea as Nepafinac, delivering an analgesic effect to the corneal surface and directly affecting nociceptor activity. Nepafinac has the ability to penetrate into the eye due to its lipophilic, uncharged properties. This means that it provides specific activity in the anterior chamber. Once within the eye, Nepafinac is hydrolyzed to the more potent form Amphinac, a non-steroidal anti-inflammatory drug or NSAID. Amphinac irreversibly binds to COX proteins, inhibiting their activity and the production of prostaglandins. In preclinical ex vivo studies, prostaglandin synthesis was reduced in the iris ciliary body following topical dosing with Nepafinac. Elevro suspension is the only prodrug NSAID formulated for once daily post-op use. It contains 3 times the concentration of Nepafinac and approximately 40% smaller particle size compared to Nevanac, Nepafinac ophthalmic.
Session, please. And I would invite Professor Azad and Professor Atul to kindly take over from here for the next session.
Lens over lens.
Professor Azad and Professor Atul, can you take over from here, please? In that case, I would request Dr. Ajay Arora to kindly start the session, retina session.
Good evening, sir. Can you hear me?
Yes, I can very well.
Yeah, I'm just trying to see if I may not, my video is not coming, so maybe I should just link up once more. Maybe Bhuvan, sir is there, Dr. Azad is there, sir.
Yeah. Dr. Azad is here now. Welcome, sir.
Yeah. Yes. Shall we start now? We are already late.
Yes, we are running late by half an hour, sir.
So, is Professor Atul is here? Is Professor Atul here?
Sir, he is stuck in the OT. He'll join soon.
Join soon?
Yes,
So
sir.
shall we
Yes,
go to the next presenter?
Yes, sir.
I think Bhuvan is the next presenter, if I'm correct.
Good afternoon, sir.
Bhuvan is here. Good afternoon, Shobit.
Good afternoon, sir.
Yes, sir. Bhuvan, you are ready?
Sir, I'm ready. I'm sitting in the car. I stopped my car and I'm ready. I can start.
You are sitting in the car. Okay, no problem. So we will, without wasting any time, we'll, ask Dr. Bhuvan, who needs I think no one needs any introduction in this group. So I'll straightway ask Dr. Bhuvan to start his video. Bhuvan, please go ahead.
So thank you very much, sir. I think I'm audible.
Yes, you are audible.
Am I audible? So I would like to start with my presentation on redesigning the macular architecture. So we have in which the macula is involved, and some of them for which I did a surgery. And so I'm sharing my screen. Is my screen visible, please?
Yes.
Yes, it is.
Okay. So I'm just going straight away to my presentation. So this was the first case. This is a patient who had an old vascular occlusion. The patient has got chronic macular edema with areas of traction. The OCT, you can see, shows presence of global ERM with multiple attachments and tractions which are present at multiple areas. So after doing a vitrectomy, I'm removing this thick hyaloid phase and the adherent ERM with the help of a cutter. But since it is very adherent, now I'm using a 25 gauge ILM forceps to gently just remove it from the area of the disc. This membrane is very tightly adhered to the underlying retina, and because of the vascular occlusion also there is underlying neovascularization. So there are chances it may bleed or even create a break. So you have to be very gentle in separating these membranes. So now once the membrane is out, just with the help of a cutter, these 25 gauge cutters, 27 gauge cutters are very useful things for a retinal surgeon. I think they've really changed the surgery. They have revolutionized the surgery. So once the ERM is removed, I stain the ILM, and in such cases, the ILM is also usually causing tangential traction, and it causes chronic macular edema. So I did a removal of the ILM. So you can see in this case, the ILM is coming out easily. It comes out piecemeal, but still some just managed to come out successfully. So the ILM is just coming out piecemeal, and there are areas of multiple pinpoint hemorrhages which you just have to ignore. They do not cause much problem. So I was trying to do a foveal sparing ILM peeling in this case, and it's usually recommended since not a macular hole, then this remaining blood was removed. And you can see in the post-operative period from this OCT picture was this OCT picture which I got after about 2 weeks. The patient is further improving, the vision is also improving. Now coming to my second case, this is a diabetic case. You can see the macula has a tractional band over the disc is present. Now, and on the OCT, we can see this huge retinal bump with folding on the retinas. So these are very challenging cases because the vision is usually good, but the patient was very persistent. That his quality of vision is not good. He has a vision of 6/12, but he's not happy with it. And it is only because the patient has showed faith in me that I decided to go for a surgery in this patient, because the fovea still appears to be quite healthy. So after doing a complete vitrectomy, again with the help of a cutter, the 10,000 cutting, I'm just going over the bridging traction which is present there, and I'll just dissect this membrane and it easily comes out. But in diabetic patients, this is not the end. There were multiple areas of bridging tractional retinal detachment. So you have to release all those tractions for a successful outcome in the end. Otherwise, it will lead to a retinal detachment. So most of the dissection, I think most of the retinal surgeons now do with a cutter only. These fine cutters, they can just sit on the retina and do a very good dissection. So these are multiple islands of traction which are present on different parts of the retina, and just gently teasing out all these membranes and then just trimming it. The membrane which is present over the center of the macula was also causing a pull on the nasal area of the macula. So I decided that I should remove it. So this is a procedure which can lead to intense hemorrhage, but patient was given preoperative anti-VEGF, and the membrane very successfully comes out and relieves the traction over the area of the macula. So also I do ILM peeling in such cases, and the results are usually very good because such ILMs, they usually cause tangential traction, and the ILM peeling was also done. So we can see that this is the preoperative picture. And after about 2 to 3 weeks, we can see that the macular contour is just coming back to normal. This bump has gone away. The OCT is also gradually coming back. So this surgery was done on 15/12, and this OCT is of 8th of January. So approximately 3 weeks. So probably it will continue to improve over a period of 3 to 6 months. Now this was another case in which the patient had a macular pucker with a retinal detachment, old retinal detachment. These macular puckers, they are really very difficult sometimes to handle. The posterior PVR is very essential for a successful outcome if you want in such patients. So I've done a vitrectomy, I've injected a PFCL bubble, and now trying to remove that overlying epiretinal membrane, which is very tightly adherent to the underlying retina, without which I can't have a successful outcome in such retinal patients. So I'm repeatedly trying to find an edge, but initially I was not successful. But yeah, I think the main thing in these cases, you have to be very, very patient, and you have to have even a lot of experience of removing such membranes. And I think patience is the most important thing. So finally, I just got an edge under the PFCL. PFCL here acts as a third hand. It pushes the retina down. It provides me support pulling the retina down so that I can just remove the membrane. So now I have got an edge, and I'm just lifting it the edge from the retina. And you can see that this is such a thick membrane which was present, and it is still very tightly adherent, and I managed to remove it from the macula. Now we can see that the macular contour has also become better. So I'm trying to pull it. I think this is something I should have avoided, but eventually then I used my endolyte to push the retina back and successfully remove most of the epiretinal membrane. Following that, air fluid exchange was done. So this is an interface vitrectomy we do with the air fluid exchange for the peripheral vitreous with the help of a cutter. And the patient had a posterior break, high myo patient with a posterior break. So the fluid was drained through this break only, and this PFCL bubble was removed, and following that silicone oil was injected. So this is the post-op pictures. We can see that the macula is relatively healthy, that it's well lasered. But what happened after 3 months when I planned a SOR, I did a OCT, and I can see again the formation of a very thick ERM which has formed over the overlying retina again. So when I did the SOR, I again decided to remove this membrane. These membranes are known to form again and again. So again, before removing the oil with the help of a ILM forceps, I removed this membrane over the macula. If you just remove the oil and leave this membrane, it will compromise the final visual outcome. So you have to be very careful while handling these such macular cases, that you do not damage the underlying macula, because retina is not so forgiving. So after removal of the membrane, I think the macula is quite clear. Just trim these membranes, and the silicone oil was removed, and the patient has gained a final vision of about 6/12 post-SOR. Now, this is the last case I was just showing. This was a case of a pathological myopia which had a old macular hole. And this case I'm showing because this is the most difficult ILM peeling I have done up till now in my whole career, which is not very long, I can say. So, but this is, you can see the scleral show, the retina is severely atrophic. We can't even make out where the retina is. I was very scared whether I should go ahead with the ILM peeling or just leave it, but I still proceeded with it. So in such cases, I can just even create a retinal break or damage the retina, whole of the retina, because the retina is very thick. There was no contrast. So, and the ILM in such cases also comes very in very small parts, piecemeal. It's very adherent to the underlying retina. So initially I removed the nasal part, then I removed the temporal part. I didn't try anything like temporal flap or a cabbage or closing the hole, because the hole was even not visible on table. The whole of the retina was so atrophic that I could not even properly visualize where exactly is the fovea. So I managed to do ILM peeling of the approximately whole of the macula and left the patient. So this was the patient pre-operatively, and this is the patient, the OCT that was done under gas. This is just a 1 week post-operative done under gas. That is why the retina is appearing more thin, but the hole has completely closed. So I'm just waiting. It will take about around another 2 to 3 weeks for the gas to go away. And then probably then we can see how is the functional outcome also. So that is the end of my presentation. And thank you very much for allowing me to present and for your attention. So over to you, Dr. Azad. I'm over, sir.
Thank you. Thank you for wonderful videos. And I saw one of the videos where there was a epiretinal membrane over the macula also and over the disc also. And you are removing the membrane, or there was a fibrous tissue over the disc.
Yeah.
And so you were lucky that not much bleed was there. But normally if you remove the tissue from the membrane from the disc, normally there is a lot of blood bleeding is there.
I fully agree with you, sir. I also said that the chances of bleeding are very high. So I was definitely lucky. My luck is always there. I've got very good mentors like you and Dr. Bharti with me. So I always have good luck, sir.
So it's really, for all the people, who are doing vitreous surgery, I think he may not be very lucky as Bhuvan is lucky. Wonderful presentation. Is any question to him?
Sir, can I say a word?
Please, Ajay.
So this is just an observation, Bhuvan, especially his last case where he had a very, a membrane which was hardly visible because of a poor contrast. So I've had a few cases recently. So what I have done is just a suggestion is that instead of using brilliant blue, in these cases, I've started using ICG. So ICG gives me a better contrast. We use with 10% dextrose, and we use at a very low concentration, and you get a nice contrast. So then sometimes when it's very difficult to make out these membranes, something becomes visible with an ICG, and then you can your surgery becomes a little more comfortable than when you do with the brilliant blue. Sometimes I don't get very good staining with brilliant blue.
20 seconds after the dye.
Exactly. After this video, I also went and searched into literature, and I came to see that this Andrew Chang from Australia and one of these Japanese person in such pathological myopia cases, they do the ILM peeling with triamcinolone. So probably the crystals, when they're removed, so they get a better contrast. So maybe next time if I get such a bad ILM peeling, I would first try to use triamcinolone. Then of course ICG is always there, but since we always fear that ICG has got some retinal toxicity, and that is why we stopped using it.
So there's a recent article which has come up just about a year back, which showed that they looked at the toxicity of ICG. So when you use it at a very, very low concentration and use it only for 1 minute, and your illumination is cut down, the toxicity levels are hardly any.
Right. So if there is no other comment, shall we go to the next presentation? Is Professor Atul here? Has he joined?
Not yet, I think.
Not yet. So we'll go to the next presentation. And next presentation is by Vivek Dave. Is Dr. Vivek Dave here?
Yes, Dr. Azad, I'm here. Good evening. Am I audible? May I go ahead? Yeah. So I'll just share my screen. Please do confirm if my screen is visible.
All good, sir.
Visible.
All right.
Visible.
All right. Sure. So I'll go ahead. Thank you, Bhupesh, and thank you, Bharti Eye Foundation, for having me as a part of this video series. I'll give a small case presentation on endoscopic iris cyst excision. Yeah. So my case was an 18-year-old male with a marfanoid habitus. The left eye was lost many years ago and he had an artificial eye. The right eye had a history of vitreoretinal surgery with silicone oil in situ done elsewhere 2 years ago with cataract extraction. The right eye also had history of recurrent iris cysts, for which the patient had undergone 2 sittings of cyst aspiration and sclerotherapy over the last year elsewhere. So this is how the patient looked at presentation. The vision was counting fingers close to face. And if we see, there was anteriorly displaced iris visible all around. And right in the center, one can see this translucent iris cyst in the visual axis. If we look at the slit photograph, we can appreciate the fact that the ballooned iris was nearly touching the corneal endothelium at many places. In fact, areas where the touch was chronic had actually developed a corneal decompensation. Because we could not assess the posterior pole, we did a B-scan ultrasound, which showed an oil-filled globe which had emulsified. And also in one area, we could see what was looking like a possible shallow recurrent retinal detachment. This is the anterior segment OCT of the same patient. Here we can very well appreciate how the iris has ballooned ahead and adhered to the corneal endothelium at many places, rendering the anterior chamber very shallow. So if you look at the clinical situation and the planning that went ahead, this was a one-eyed patient, had multiple VR surgeries done before, had recurrent retinal detachment as per the B-scan, had a history of recurrent iris cysts which were treated, but were failed on sclerotherapy treatment. So going by this background, we planned for an endoscopic iris cyst excision in this patient and laser photocoagulation of the cyst base, along with VR surgery to resettle the detached retina. So I'll go ahead with the video. I hope the video is playing. This is the silicone oil removal which is being done. After the SOR was done, the anterior chamber was formed by viscoelastic, slowly dissecting off the iris from the corneal endothelium and rendering the anterior chamber deep again. So this ensured that the entire cyst was cleaved away from the cornea. Once this was done, we took a Sinskey hook, and then the hook was inserted between the IOL and the iris cyst, separating the IOL from the iris cyst and ensuring that odd adherence of the iris from the underlying IOL was released. When this is done, the cyst actually collapses. So you will find that the chamber has deepened well and the protuberance that was visible behind the iris is no longer visible. Now, a corneal incision is made through which an endoscope was inserted, and through one of the side ports, we inserted the cutter. The endoscopy video, this is the best quality that is available in the machine. But if you see, this is the iris, and below you will see another brownish membrane, which is actually the wall of the cyst. And this wall is being removed by the cutter here. To the extent possible, the entire wall of the iris cyst was cleared from the posterior aspect of the iris. Once this is done, we still find small remnants of the iris tissue right at the base of the iris. Attempting to remove them can actually cause a lot of fresh bleeding from the iris base. But if you leave them, there is a chance for the cyst to recur. So that is the reason, after all of this is removed, as is visible here, an endoscopic photocoagulation of the cyst base is done, so as to ensure all the remnant cells are well photoablated. Once this was done, this is how the anterior chamber now looked like. It was looking a lot like what a normal eye looks. Now, when we looked inside, we saw the retina was looking very shallowly detached. We cross-checked it by laser spots, and we found that no laser spots were being taken up. So this retina was then settled by doing a drainage retinotomy, lasering the retinotomy and going ahead and doing a 360-degree endolaser and finishing the surgery with a final silicone oil injection. So this is where we were 3 months post-op. The vision from counting fingers had improved drastically to 20/250. And keeping in mind that this was a one-eyed patient, this was a very beneficial outcome for him functionally speaking. If you look at the slit again, I'm sure you would appreciate the depth that the anterior chamber had now regained once the cyst was gone. Just a comparison once more. To the left is our pre-operative situation with the flat anterior chamber and the iris cyst and the ballooning iris. And on the right side of the screen, if you see a quite normal looking anterior chamber post-surgery. So we've had experience in previous patients like this too. All these cases were cases where previous iris cyst excision with sclerotherapy injection was attempted, but we had a recurrence. So to the left is the pre-operative, to the right is the post-operative picture, where all of these cysts have been removed by endoscopic cyst excision and lasering of the iris cyst base. This is the second case, which also had a similar approach, which again was successful. And this was one more case. Again, you can see a lot of iris cysts, multiple lobulated ones, and this is how it looked post-cyst excision. So in sort of conclusion, I think endoscopic approach is a good approach to tackle iris cysts which are recurrent in nature. By literature, we would find that injecting a sclerosant to get rid of all the cells or epithelial cells is the standard of care. But in situations where this keeps coming back, the only best option would be to approach endoscopically so as to not have to sacrifice iris tissue while attempting to remove the iris cysts. So thank you so much for your attention. In case there are questions, I'll be happy to take them. I'll stop screen share now. Thank you.
Thank you, Vivek, for a very well managed case. And we all know that iris cysts are very notorious for recurrence. So keep a watch on your cases. That's very important. And the other thing is, you said endoscopic. That's the the best possible management. But everybody doesn't have the access to endoscope. So in those situations, one has to manage. Shobit, is Shobit here?
Yes, very much so.
Shobit, would you like to say, if there is no endoscope, how can you manage such cases?
Some simple excision using the vitreous for the best. And I have not had a recurrence. I have solely done laser ablation of the edge of where the junction of the pigmented and non-pigmented area is. So I've just done 3 cases over my years because we hardly see them. We used to see them days. We don't see them so often now.
So if there is no comment, then we go ahead with the next presentation. And next presenter is no one else other than Dr.
So there's one small comment. I think must congratulate Vivek for detecting the irises, because normally when we have posterior synechia and all that, what we normally think is iris Bombay. And when you have iris Bombay, what we were taught many, many years back, which the youngsters today won't even know, it was the 4-dot iridotomy. Nobody does that now. But, so the first thing would be that I think what Vivek has done is great. Maybe, Vivek, one small question, just for all of us. How did you suspect an iris cyst and not an iris Bombay? Did you do a UBM?
Yeah, Doctor, good question. In this one, actually, there was this cyst sort of a thing which was visible in the visual axis.
Okay.
That is the reason why it got picked up. Just as an extension of what you are saying, this was actually seen in a different clinic and was, like you are correctly saying, actually advised for a YAC PI, because the entire presentation initially looked like an iris Bombay. But I think the patient was lost to follow-up. And by the time the patient came back, possibly the cyst had enlarged. And that is why when I ended up seeing, I could see that little protuberance in the visual axis. Otherwise, I would have also missed it. So one learning that I am taking from this is, if this sort of a presentation is seen, it may be worth imaging to be sure that there is no such growth behind the iris before we write it off as a routine iris Bombay.
So you would advise an anterior segment OCT in all these cases?
I think in situations where I find this sort of a ballooning, but I do not find the IOP high. This patient had an IOP of around 8. So that does not fit into the entire constellation of findings for an iris Bombay. Plus, he was a pseudophakic patient. I don't recollect seeing many pseudophakic patients who go into an iris Bombay. So that, I think, would again raise a red flag and should prompt us to see if there is something getting harbored behind the iris.
Right. Thank you.
Right. So the next presenter is Dr. Sobhit Chawla. I don't think he needs any introduction or anything. He's a well-known, wonderful, wonderful retinal surgeon and a very good photographer and a very good cook. He's a very good cook as well.
Just finding my file. I don't know where it. Just give me a second, sir. I opened my file, but I don't see it on the. Why isn't my share screen showing? Can you see the screen now, sir?
Yes, yes, yes.
Thank you very much, Dr. Bhupesh and Dr. Bharti. So I'll be speaking and sharing a few videos on myopic traction maculopathy, which is a surgery very dear to my heart, because many times it's not easily detected, and before OCT, cataracts used to be done in a hurry, not realizing what lurks beneath. If you look at this, this is just to explain my logic. When you see, I'm comparing two entirely different entities. This is a slide of X-linked and this is a slide of MMT. See how much the ILM is under traction. So this slide sums up my philosophy for operating these patients. I won't go into the grading. I will come straight to the simple classification which I use. Either it's a simple myopic maculoschisis or a compound, where you have splitting at various levels. I call it compound. Where you have splitting at one level, it's simple. Not that it affects the management much. So let's see this first patient, a 30-year-old female. She came with 6/12 vision, myopia, and early posterior subcapsular, and we detected this myopic fovoschisis. Now, I like to study these cases a little deeply. So what I had detected at that stage, and I made a note on the case sheet and also pointed it out to my fellows, was distraction on ileum temporal to fovea in this patient. As time progressed, I also did not tell her to go for an early surgery. She was told the possibility, and we said, I like to document decreasing vision in these cases before I jump into surgery. She came again later. Now you see the schisis has become, in 1 year, it has become much more. And temporal to ileum fovea, you see still that traction. So we decided for surgery, and she was more than willing now. I like to combine these myopic surgeries with a phacoemulsification. So what I like to do in these patients is not a fovea sparing surgery, but a fovea fortifying surgery. The fovea is cystic. So what I do, I create an envelope to fortify the fovea in case a hole develops. There is the ileum substrate to seal it. So I create this small envelope which has 3 or 4 nice leaves, and I do a wide ileum peel. This is the nasal ileum which was not. That is the ileum which was under traction. So I release this traction, keeping the OCT in mind, and I go ahead with the surgery. Then I trim these leaves a little bit using 50 suction. and a cut rate of about 1,000 or so. So this is just after surgery. I normally, because these are myopic eyes, I don't use SF6 that much. I prefer to use something like 8 or 10% C3F8 because it gives a more, it combats hypotony for a longer period and allows the eye, and instead of 17%, 8 or 10% C3F8 lasts about 10 to 15 days, which is good enough. See the traction relieved here. Gas bubble in place. That was the pre-op picture. This is 1 week post-operative. You see the ILM flaps later in the course of post-operative course, and 3 weeks you have 618 plus vision. Another patient, a compound myopic schisis, and again what Bhuvan and Ajay were discussing, the definition is poor, but so I leave my dye in about for 20 seconds, but without fluid air exchange. And then I do a peel, a nice white peel. So post-operatively with phaco and surgery in this only eye patient, we got a 20/40 visual acuity. So a small advice for anterior segment surgeons: do a good fundus examination before operating a cataract in a myopic patient. Be wary if the cataract and visual loss do not correlate, and OCT is a must. There is variability of response to surgery. Combined surgery works better. History of recent progressive decrease in vision is a good prognostic marker for MMT surgery. And peripheral retina checkup is very important. It's not unusual to see a lattice with opens and which you have to treat with endolaser there and then. In the absence of macular hole, ILM peeling can give results. In my cases, even with a macular hole, I do ILM peel. I didn't include those cases, but I have a fair number of cases now, more than 6, where I have done ILM peeling with myopic macular hole along with schisis and got a fairly good result. I don't do macular buckle. Another patient, post-op. So that's it. I hope made some sense.
Thank you very much, Shobit. Is there any comment or any question? Ajay? Hello?
You're muted, Ajay.
Ajay?
Muted. So I think wonderfully shown by Shobit. We've done cases of myopic foveus cases, and I think these are the cases which respond very well to a fluid gas exchange. Oil should not be done in these cases. Gas, gas injection is the answer. So oil should never be done because it all started sometime back in 2013 when the first paper came out from Korea, where they showed about 13 odd cases or 11 odd cases where they're done, and they showed success in all these cases with gas injection.
What about your reflection on buckle? Because between Professor Hassan Mortada and Barbara Parolini, there's always a debate. Macular buckle. I've been a follower of Dr. Mortada, and I've always done, and I showed you in my cases the traction on the ILM. I'm a firm believer that a good management of the ILM can do justice in most cases.
So if you give me time, I speak for just half a minute. So I had this case of myopic foveus cases where I operated, the patient settled, came back after a year, there was a recurrence. So we decided that we'll do a macular buckle, but macular buckle was not available. So we created a macular buckle the way it was described by Egyptians using the dental wire, and did that and put in the macular buckle. She settled again, but then the macular buckle extruded. Then I went back and did a fluid gas exchange, and she finally settled. So I don't know what really works, but I think fluid gas exchange does work in these cases with a good ILM peeling.
Yes, so if there is no other comment, we go to the next presenter, and I think Ajay, you are the next presenter, no?
Yes, sir.
So Ajay, everybody knows him. So Ajay, can you go ahead with your presentation?
Yes, sir, I'll do that. Is my presentation visible?
Yes, yes.
So at the outset, I must thank Dr. Bharti, Bhupesh, and the entire team of Bhartiya Foundation, Professor Azad, Bhuvan, Dr. Pandey, and everybody for giving me this opportunity. My talk is on a large macular hole cabbage technique. And so this was a patient who was a 61 years old female who presented with blurred vision in the left eye for about a year. She had some amount of cataract. There was a cup-disc ratio of 0.4. There was no peripheral lesion. Visual acuity in the right eye was 6.9. In the left eye was 6.36. She was non-diabetic and non-hypertensive. So this is the picture of how the macular hole was. You can see a cuff of fluid, and here is the hole with the base diameter was almost about 980 odd microns. This is the angio-OCT done at the superficial capillary plexus, and this is done at the ORCC. And you can see here is a free-floating operculum-like thing, which is from the macular hole. So these are some of the indices, but essentially, let me just go on with the video. So this is the 25 gauge vitrectomy with the chandelier. You can see here the vitrectomy being done. So initially a cold vitrectomy, and then I will inject triamcinolone. So we inject triamcinolone, and you will see a PVD being done. That way we are sure that we have removed. So the PVD has happened, and then the entire vitreous is cleared off. Now I have done this staining with the ICG, and you can see the ILM peeling being done. And so this flap over it, then we go on to and get the next flap. So I do 3 or 4 flaps. These are used forceps, so sometimes they don't hold. But the ICG gives you a wonderful contrast, and it's very easy to pick up these membranes. So you can see here how well this thing is opposed, and I'll and this is followed by a fluid gas exchange. You know, sometimes these floating flaps, as I think Vishal has been doing it under the PFCL, which is also a good idea. So we've done a fluid air exchange, and so that's the end of the surgery. I'll just go to that. So essentially, so this is what was the patient who presented, and this is the macular hole closed. So please note here that actually there is almost an apposition occurring of layer by layer. We did an OCT of this patient post-operatively. This is the DCP slab. and this is the ORCC slab. And if you look at it carefully, at all slabs in the angio-OCT, there is a closure happening. So this patient, we are going to closely follow up. The visual acuity on 18-day post-op has improved. What I wish to point out is we had described this technique way back in 2016, and from then onwards we have been doing a cabbage technique, which basically this was the case which we had published in 2016, where there was a very large hole of almost 1258 microns, which we closed with 3 flaps. And you can see here, this was 3 weeks later for the same patient, and this is on 14 weeks. There was a fibrous tissue here, but there was some apposition of the layers. Patient's visual acuity had improved to 618 then, which was hardly, we could not believe it, and we were very happy. And since then, we have been following this technique. The rationale for this technique, large macular holes, when managed traditionally with the ILM peeling, would end up having a type 2 closure. So what my proposition is that every ILM has a vitreal surface and a retinal surface. So when you oppose these flaps one over each other, so on one surface, you will have the vitreal surface, over it, there'll be a retinal surface. So there are irregularities on the surfaces. When they come together with each other, they sort of interlock like a Velcro tape, and that actually works well for closing the macular hole. You really don't have to push the ILM into the macular hole because that would cause damage to the RPE. So by doing this, you create a closed compartment within the macular hole by the ILM leaves, which actually acts as a closed compartment. So RPE pumps becomes active, and that maintains the macular hole. So this is why we call this a cabbage technique, because of the multiple flaps. And I think this works well in my hand, and people will call it as various names, but I think it's essentially the same. Thank you for this opportunity, sir. Thank you very much.
Thank you very much, Ajay. And for a new technique, it's a nice technique. And my question is that why this new technique?
So the options, we have to first look at what the options are. The options are an inverted ILM flap from the temporal side, which for very large macular holes, which I have shown, which are over 1100, 1200 microns. So these holes may become smaller, but may not have a picture of a primary closure. They would appear like a secondary closure. So in those cases, when you do a flap technique like this, I believe there is a centripetal force which assists in the retinal edges moving closer together, and by not pushing the ILM into the macular hole, you're not causing any damage to the RPE. So you are able to get a good hole closure, and you end up having a primary closure, which is not possible by other techniques.
Do you mean that this technique will work very well if there is an extra large hole?
So I have done it up to 1300 microns, sir. I've not done anything larger than that. And I've been able to close, I've been able to close holes of that level. Yes.
Right. Thank you very much.
Thank you, sir,
for your nice presentation. Very good video and very good result.
Thank you.
Shall we go to the next presentation? And is there any question? Shobit?
No, I think I follow the same technique. Only thing, I trim my flaps. I don't leave them very large, and I just cover the hole with them, and I do a wide ILM peel in the larger holes. Typically, this is my standard technique for holes larger than 400.
So can I make a small point to end this discussion?
Sure.
So I do the same thing, but I do it under PFCL as Dr. Ajay mentioned. And I don't do a large peel because it's basically not a tractional relief, it's a plugging technique. So a small peel also will suffice, and even air and not gas will do the job after the surgery. So I don't do a wide angle peel if I'm plugging it in. I do a small peel, but I do it under PFCL, and the results are excellent.
Very good.
So I've been using, I was earlier using C3F8, but now I've started doing with SF6 and it works really well. And we had done a small study some years back where we had, we thought larger the peel for should be proportionate to the size of the hole. That's what I thought would remove greater tangential traction. This is way back, almost about 14, 15 years back, but it did not substantiate. So from that time onwards, the maximum I do is an arcade to arcade peel, but yes, a larger peel may not, as Vishal said, may not have directly proportional result to the size of the peel maybe. But I think, yes, Obit is right that, yeah.
Very long tamponade is not needed in macular hole surgery.
Not at all.
People have done surgeries, without even injecting the gas. In fact, I have also done, of course, I don't have much experience for very large holes, but definitely macular holes, you can, without some of you, if there is a recurrent macular hole or a very large macular hole, of course, you should go with a tamponade. A gas tamponade, either C3F8 or maybe, SF6 is good enough. There's no need for long tamponade.
सर एक चीज है कि थोड़ा सा डर लगता है बिना टेम्पोनेट किए सो और दूसरा पेशेंट्स they will go home and they will ask Google uncle कि people are doing tamponade, they are asking us to lie face down, so if we don't do that, that becomes a medical legal issue. So I tell them tamponade, we know that they will not be doing face down so much as we tell them. So I tell them, all my patients, भैया 10 घंटे 10 दिन के लिए. And though that is a little too much, even 6-7 days is enough. But well, that's what I do. It's medical legally makes sense.
I would like to add one thing, sir. I think most of now everyone is doing this technique of closing the macular hole, plugging it. Some do an inverted flap. So what I do is the same technique, but sometimes I don't do it under PFCL like Vishal. You can just put a drop of viscoelastic over the flap once it's over the macula. So it stays there even after the end of the air fluid exchange. And I think if the macula is well covered, as Vishal said, and I think you don't need a very long tamponade, sir. With air only, it is sufficient. But some very large holes, although we get very good anatomical success with these new techniques, but the main thing is that the functional outcome is still limited. Because we are achieving a closure, but the underlying atrophy is already there.
That is true. That will tell, how much damage is already.
Point, sir?
Yes, Sobit.
What Bhuvan was pointing out, I think if you leave the flap with the little edge on the temporal side, you really don't need anything. And BBGs has not been shown to be toxic to the RPE. So when you just do the fluid air exchange, keeping on the disc, tilt the eye a little bit, the flap falls beautifully. I feel what Ajay also pointed out, least maneuver, no attempt at stuffing or putting under just a nice cover of the hole and it suffices. SF6, on the 5th day you do an OCT and you find your hole is already closed in most of the cases.
Right. We go to the next person. Is Dr. Atul, Professor Atul has joined or not? Is he coming? No. Oh, I think maybe he's busy somewhere. Anyway. So next presenter is Vishal. Dr. Vishal?
So good evening.
Good evening. How is everything? Vishal?
So everything fine, sir. Aashirwad hai aapka.
Chalo, theek hai. Go ahead. Go ahead with your presentation.
Yes, sir. One second, sir, there is a problem. So can you see the presentation now?
Yes.
Okay, thank you, Dr. Bharti and Bhupesh and Dr. Bhuvan for having me here. I'll be speaking on myopic foveoschisis with macular hole. I'll just give a very small brief before the videos and the main surgical part. That pathological myopia, which is globe elongation and a refractive error of at least -8 diopters or axial length of greater than 26.5 mm, which we are dealing with here. And basically, pathological myopia has a very high disease burden, and myopic fovea is present in about 30 to 40% of patients having more than 8 diopters myopia. So coming to the surgical part of this disease entity, there are 4 main problems which I would like to discuss here. The first is, of course, the visualization of the posterior pole. Second is the obvious high axial length of the eyeball, sometimes more than 30 mm. And the third is the posterior vitreous detachment, which is a big difficult task in these cases, because there is a cortical vitreous, there's a universal presence of vitreous chiasis and a cortical vitreous layer which is adherent to the retina. And of course, a common sound surgical technique, to get the optimal results in these cases, in these difficult cases. So the first point is visualization. So in a routine macular hole case, even if there is a small amount of lenticular opacity, you would just do a macular hole surgery and maybe plan a cataract surgery afterwards. But in these cases, even a small amount of lenticular haze creates a lot of aberrations during the macular surgery. And because of the low contrast of the macula, the view is very important. So combined phaco-vitrectomy is the treatment of choice here. I would say that in any case, the patient is around 45, 50, and even a mild haze of the lens, you should go for a combined phaco-vitrectomy. It clears the view to a considerable extent, and all the aberrations are gone. You can just, after the focusing part in this video, you can see how sharp is the view. You can see the ILM and the posterior pole with great contrast and crispness, and you can do your maneuvers in a more safe and effective way. So the first thing is a combined phaco-vitrectomy after most of these cases, in most of these cases. The second is to how to compensate for the length. As you know, all these instruments are meant for routine axial lens, which are available commercially in the market. So the standard techniques is, to make a posterior port around 4.5 to 5 mm, or to remove the trocars. But sometimes that also does not work. Or use a custom-made longer forceps. So what I've seen is the problem lies when there's a long axial length. So you go, vertically with the forceps, and the shaft of the forceps, touches the rim of the non-contact viewing system, and that creates a problem. It tilts the viewing system, and there's a problem with the stability of the image. So in cases with you can see this high axial length, posterior cephaloma, low contrast, you use a irrigating lens or a macular lens, and it gives you a great magnification and resolution. And the problem of touching the forceps with the non-contact viewing system edge is circumvented, and it works really fine in these cases. So if you're comfortable with irrigating lens, that's a great option in very long eyes. So posterior ports, contact lenses, removing the trocar, and even that does not work. Sometimes what happens is if you tilt the eyeball a little bit, and you can use, if you're comfortable using your left hand, the right hand forceps might not be reaching the posterior pole. So this is a case in which the left hand is being used, and it is comfortably reaching the posterior pole, and you can do the peeling if you're comfortable with your left hand. So that is one way of managing the length problems of these eyes. The third point is PVD induction. I see, as this is the single most important step, and without adequate PVD induction, you won't get a good staining of the ILM, and PVD induction in this case is particularly very difficult. So this is a technique which we described. One technique is which we described in pediatric RDs way back in 2016, and here sorry. So here, we have stained the posterior pole. We have done a pore vitrectomy. We have stained the vitreous with triamcinolone acetonide, and you can see that diffuse staining of the cortical vitreous after doing the pore vitrectomy. So after that, we inject a small amount of PFCL bubble, not much, till maybe the arcades. And this technique also works fine in these eyes. And then you start peeling the cortical vitreous. You create a cleavage plane, and once the cleavage plane is sufficiently wide enough, you pull it upwards so that the PFCL bubble goes into that hole and cleaves the vitreous. So thus by creating a PFCL, you can use your other blunt instrument like a light pipe to make the opening a little more large, and then you fill that hole with more PFCL so that it cleaves the PVD till the equator. It's a very safe and reproducible technique of creating PVD. And Then you can use your section from the cutter to extend the PVD. So this is one way of using of inducing PVD in these cases. The second is, of course, the routine way. There's no other way in these cases where the contrast is very poor, and actually using PFCL in these cases is actually hampering the PVD induction, because you increase the length more and you won't be able to grasp the cortical vitreous with the forceps. So the only way is using a lot of patience, using staining and restaining with trimestone acetonide, and then using a combination of forceps, cutters to peel away the adherent cortical vitreous. And that is very important. You need a lot of patience, and for removing it. You can see the adherence of this layer over the retina, and without this removal, the surgery is not a success in any ways. So this is the routine way which we all do it, and the other way which I described was under PFCL. So, but still, doing everything like this, and we still get very, very variable results, and more often we get suboptimal results like type 2 closure as shown in this OCT, or late reopening of folds, or maybe a primary failure of the surgery also. So we need to tend to have a sound surgical technique which might not eliminate suboptimal results, but maybe minimize it. So over the years, learning from our past mistakes, we have what we do right now is standard techniques which we have described in the previous videos, plus inverted ILM peeling with a large ILM peeling, which I'm going to show in this case. So this case was a 60-year-old female. The right eye had a finger counting close to face, recent onset diminution of vision, pseudophakic eye. The axial length was 30.5 mm, and there was a myopic foveaciasis. We can see some traction, and there is a full thickness macular hole. So making a posterior port around 5 mm from the limbus, and then we induce PVD by staining and restaining with trimestone acetonide, and then rechecking by again injecting trimestone acetonide and checking the free flow of the crystals here. Now you can see the the posterior pole fluid here. So we stain here with first with the trypan blue in order to visualize any ERM over the macula, and now you can see that some trypan blue has gone subretinal, which is very common in these cases because the posterior pole is elevated here, and but there is no ERM staining. All the dye is subretinal here. Then you stain the posterior pole with the brilliant blue, and this is the thing I want to just press on, that you inject a small amount of PFCL bubble here, so that all the and with the gentle suction, all the posterior pole fluid and the subretinal dye gets aspirated very easily. Don't inject too much, just a small bubble which pushes the fluid and the dye from the macular hole. As you can see, all the viscous fluid and the dye is coming out of the hole here, and so the macula is flat now. And now you can safely inject a large bubble of PFCL over the posterior pole. Now you start the peeling with the pinch and peel technique. So the point here, you go, of course, in an inverted ILM flap, you go towards the hole. But as Professor Hassan Motada taught us, the size of the peel is very important. So you have to identify the edge of the excavation, and you try to peel it as close as close to the edge as possible, so that there is a lot of redundant retina, available for the hole to close. And then you just go, you drag the ILM towards the hole. As you can see, this is the same technique, the cabbage technique described by Dr. Ajay. The difference is it's a high myopic eye. The second difference is being done under PFCL. But the repositioning becomes so simple under PFCL, it becomes a ropey and a sticky texture. You just have to drag it, and there is no underlying retinal trauma. And the beauty of it is that after the aspiration of the PFCL also, the plug of the ILM remains there, and very little chances of flap loss here. So then you go under air, do a lot of interface vitrectomy, and gently aspirate the PFCL. So once you have tucked that ILM plug inside that, there are very little chances of getting displaced even after aspiration of the PFCL. As you can see, that blue dot is till the end when the last drop of PFCL is aspirated. So we had an excellent result in this case also, and the post-operative 8 weeks was 1.0 log my units. So the lessons we have learned over the years is myopic foveaciasis with macular hole, is a complex surgery with varied intraoperative surprises. And of course, a thorough preoperative workup is very essential for the desired outcome. The few tricks and tips are that a combined procedure, a complete PVD induction with multiple staining, restaining, posterior supports are the key to success. And finally, a thorough preoperative counseling with a very clear communication about the chances of failure, about late reopening of holes, and even after surgical success, a modest improvement of vision should be done to the patient very clearly. Thank you, everybody. Thank you so much.
Thank you very much, Vishal. And I think the next session is waiting. We are already half an hour. So we'll close here. And all the presenters, we had a wonderful video presentations. And everything went on very well. Thank you, Sobit. Thank you, Ajay. Thank you, Vivek. And thank you, Vishal. And thank you all. And of course, Dr. Bharti, Dr. Bhupesh, Dr. Neha, and Dr. Bhuvan. So thank you very much. Thank you very much, Sobit.
Thank you very much. Bye-bye. Thank you.
Bye-bye. Bye.
Thank you, sir. Thank you very much.
Dr. Bharti. Thanks, sir.
So now I would like to invite Mohan for our next session. Mohan is the moderator. Mohan, where are you?
Hi, Sudhank.
Yeah.
Yes, Sudhank.
Great, great, great. I can.
OPHTHALMIC represents the next generation in long-lasting relief from dry eye symptoms. With its innovative dual-action formulation, OPHTHALMIC doesn't just wet this patient's dry eyes. OPHTHALMIC stabilizes the tear film and goes deep to provide long-lasting hydration to the cells. In dry eye, the tear film is compromised, stripping the ocular surface of a needed protective layer. The underlying corneal epithelial cells become distressed and add to the patient's nagging discomfort. In certain patients, artificial tears are often in a constant race to keep up with evaporation and maintain a moist tear film. Dual-action OPHTHALMIC works hard to achieve long-lasting relief from symptoms. The unique mechanism of action enables its innovative advanced formula to protect and hydrate the tear film while simultaneously protecting the ocular surface with moisture. Furthermore, the dual-acting formula is absorbed into the desiccated corneal epithelial cells where it provides long-lasting hydration. When your patients experience dual-action OPHTHALMIC, their relief will be apparent. And this long-lasting relief will be even longer-lasting thanks to the deep hydration delivered with every drop. They may even feel as if they have reached a new state of ocular eye comfort. Experience dual-acting OPHTHALMIC. Achieve long-lasting relief.
Welcome, Mohan. Welcome, Purendra.
Thank you, Sudhank. The pleasure.
Satanshu and Dr. Chauhan.
Thank you, sir.
Waiting for Vidushi whenever she joins.
Sudhank.
Yeah.
Sudhank, actually, I'm not keeping well. I had quite a bad reaction after my second dose of Covishield.
Oh.
Yesterday. Yeah. I just came in because.
What was the problem? Mohan, what is the problem you're having?
No, the first dose was okay. The second dose I had yesterday. And been having severe
malaise.
Malaise and fever. And vomiting also is there.
It is common. It is common.
Second dose.
It's common in younger people. Mohan, you have gone younger after the first injection.
That is true.
Just took a Dolo 650 and came here because of my commitment. I didn't work because every time I've never missed even a single Delhi film festival with Sudhank Bharti. It is such an amazing experience to be here.
But you are sitting in OT dress.
Yeah.
You are doing OT?
No, I was working the whole day. I was working, but the only thing is I was not operating today. So I was working, but since afternoon, since afternoon I'm feeling a little
Uncomfortable. I can see from your face that you are not comfortable.
Yes, yes.
Yeah, we can make out. Yeah.
Yeah.
We will start the session. We are already running about 35 minutes late.
Sir.
Thank you, Mohan. And
Thank you.
if you continue with us, beating aside the COVID malaise, it'll be wonderful.
Yeah, I'll be there.
To have
As
your
much as
comments. So I have a request from Satanshu that he wants to present first, and I gave him my first slot. I'll then automatically go the last after Vidushi. So Satanshu, you share your screen and start the video, please.
Thank you, sir. Actually, I have to go to OT. That's why I've been requested at Bharti. Good evening, friends. First of all, I would like to thank Dr. Bharti and Dr. Bhupesh for wonderful show of this film festival last so many years and making me part of it. Dear friends, as you all know, the cataract surgery has become a refractive surgery nowadays, and it is cataract surgery has become a refractive surgery nowadays. And time has gone when we used to give +3 and -3 glasses to the patients, and patients were happy. Now everybody wants spectacle-free post-surgery. And that's why the IOL has changed, which we think to be very difficult few years back and impossible. Now it become a routine surgery, our OT. And everyone should be mentally prepared for it if and when needed. There are different indications of the IOL exchange. Main is the IOL power. This wrong calculation, especially in the high myopic or high hypermetropia patient. Unhappy patient, especially after multifocal lens. Dislocation of lens that was initially positioned correctly because of pseudo-exposition.
Sir, your video is
Can you hear me?
Sir, we can hear you, but your video is not visible.
Video is not coming?
No, can you just...
You have not started the video.
Oh, the video not. We will just start video. This is the PowerPoint.
Okay.
Poor positioning of the lens in the first place because of insufficient capsular support and damage to an IOL to haptic of the optic. These were the indications when we used to
Dr. Mathur,
go for. So,
Dr. Mathur,
yeah.
Can you just stop the share for a minute?
Stop share.
Sir.
Just start sharing PowerPoint. We are not seeing your PowerPoint.
Just open your PowerPoint presentation.
Can you see now?
Now we can see. Yes, now we can see, sir.
Okay. So these were the indication: wrong IOL power calculation, unhappy patient after multifocal, dislocation of lens due to pseudo-exposition, poor positioning of the lens in the first place because of insufficient capsular support, and damage to IOL haptic optic, especially in the Indian lenses. So this is the case first. This case was operated by one of my colleagues in nearby city. You can see a very neat and clean case operated by him. IOL is well placed in the bag, but patient has +3 diopter hypermetropia, and for near years to use 5.5 or 6 diopter lens. Patient was unhappy. My colleague did not try to solve his problem. Patient came to me. Then I thought if he has run away from his own doctor, he will run away from me also if I do not satisfy him. Case was operated only 6 months back, so there was no adhesions, and I could dislocate the lens easily out of the bag into the anterior chamber simply by viscoelastic and dialer. There is no adhesion, so neat and clean surgery was done by my colleague. But there was a problem in IOL power calculation because most of the time our staff do it, and that's why patient was unhappy. When the lens is out of the bag into the anterior chamber, we are using simple scissor that is available in India, making by many companies, only 5,000-6,000 rupees costing. And that is very important, helpful tool in the OT, and all of us should have this in the OT. This is the most easy type of IOL exchange surgery we can do it. This goes through the 2.8 millimeter incision. We cut the IOL not up to the 1 point to the other side, but only upper 1/3 part of the IOL. We cut it with scissor. This is hydrophilic lens, so cutting is very easy. Rotate the lens. There are different techniques. I will show you 2 or 3 techniques which we are doing by the same scissor. Rotate the IOL. Put enough viscoelastic above the IOL to protect the cornea. and below the IOL to protect the posterior capsule. Once it is in position, you again enter the scissor and cut a triangle part. We are cutting a triangle part. You can see it is so easy. There is no need of support from the other side as it is hydrophilic lens. Cut from the other side. From the same 2.8 mm incision we are using for the phaco. Now we are enlarging to 3 mm. So it is stitchless removal of IOL. This part is removed, small part. Then rotate the nucleus. Just keep in mind that you have to protect the endothelium and posterior capsule. So viscoelastic should be in enough quantity. Then just simple forceps with the serratia inside. Rest of the IOL is removed with a single dig. And you can implant the lens. And you can implant whatever lens you want to implant now. So to make the time short, I am just going for the next slide. So you can, this is another case where we have opaque lens. Many of us might have seen these opaque lenses. I have few cases of opaque lenses. This patient vision was counting finger, operated 15 years back somewhere. The doctor did not remove the lens. The patient came to me. But in this case, you see, it is difficult to rotate the nuclear lens because there are a lot of adhesions are there. This problem in the old IOL was very common. I have come to know. Rohit Shetty has done some research also on such type of lenses. So you have to carefully separate the adhesions between the lens and the iris and the posterior capsule. We are separating from the iris and the capsule. And you can see a lot of posterior capsular precipitation also there. One haptic is out, then it is easy to rotate the lens out of the bag. Again, in the case, lens was well placed in the bag. You can see PCO is also there. Once the lens is in the antechamber, now we can remove this lens. But before that, we are making incision enlarge up to 3 mm. And we are doing this scaffold IOL to protect the posterior capsule. Once the second IOL is in place, this is 3-piece we have, because we have to clean the capsule also same time. We are putting the 3-piece in sulcus. Now side port, this is to hold the lens. We have made a side port. By the other instrument, we are holding the lens and just cut it up to the center and hold it and remove it. By at the edge of the wound area, this cutting edge becomes a fulcrum. Lens move around and you can easily remove the IOL by simple one incision. In the first case, we have made 2 incision, triangle piece cut, and here you can see this. So this is another case. I put the third case. The third case is very common. I'll just show you a video. Yeah, start. Okay. It is a very common technique. Whenever we injecting Indian, especially the Indian hydrophobic lens, you can see there's a breakage of haptic or optic because of the cartridges and injector we are using Indian. This hydrophobic lens injected, you see there's a breakage of the haptic. We cannot leave this IOL in place because this is going to be dislocated very soon. So we have to remove this IOL at any cost. This is a hydrophobic lens. It is not easy to remove. So we have to hold it with the other instrument and cut it 1 piece small, holding, and we have to cut through and through up to the last part because this hydrophobic lenses are tricky to remove it as such. One part is made and we have removed it by holding by simple forceps. And this second part, and this is second part we are removing. And then you can implant the lens. And implant the lens. So thank you very much. Thank you, Dr.
Really
Bharti.
fantastic.
Thank you, Dr. Bhupesh. Thank you, Dr. Mohan.
Thank you, thank you. It was really very nice videos. Bharti, you want to start the whole thing?
I thought you will comment and then we'll start.
Yeah. Well, so, let me compliment Satanshu for the wonderful videos. The only thing differently I would have done in all the cases is that he showed it in the second case also. And I would, because I'm a little apprehensive about the posterior capsule. I don't want any injury to the posterior capsule while I'm exchanging the lens. And he did it in the second case wherein he put an IOL scaffold. It's very, very important. Bring this lens up, which you're going to exchange. Just bring this lens up into the anterior chamber. Make sure that you use a good viscoat with a dispersive viscoelastic to protect the corneal endothelium, and then put the lens as a scaffold into the bag or into the sulcus or whatever you are comfortable with, and then go ahead with this thing. The first case again, you showed that you removed a quarter. What I would have done is you showed that in the second case or the third case matter. I just cut 3/4. I cut 3/4, and then what you do is you just use what is called hand-on-hand technique. The hand-on-hand technique, wherein you use that the cut edge as a fulcrum, as you rightly said, and then bring it up. And beautifully mentioned by Satanshu, whenever you see a opacified lens, please do not yag these patients. This is the take-home message I want to sing. If you have an opacified lens, you have a doubt, don't yag. If you're going to yag, you're going to be in trouble because you're going to have an open posterior capsule and it is going to make your lens exchange more difficult. Fortunately for this patient, I think it was not yagged. The posterior capsule is still there, so he's able to put a lens in the sulcus without any problem. Hats off to you, Satanshu. Wonderful videos.
Thank you, sir.
It was excellent presentation, Dr. Satanshu. In fact, I'd want to know what is the cause of this opacification, because one of the patient I had, and I also exchanged the lens same manner. But I sent that for histopathology and found that it is hyaline material. So I didn't know what is the cause of this opacification.
These are the hydrophilic lenses.
Hydrophilic lenses.
Long time back, this type of problem has come, but now we are not seeing this case.
Yeah.
And this is kind of protein deposits in the material of these.
Calcium deposits also.
Calcium.
Yeah.
Some salt deposits that occurs, and that is inside the lens. It's not on the surface.
Yeah.
That is with the material. That gets react with the material, what material they were using, and it percolates in it, and it's not on the surface anywhere.
Yeah.
So it happens only in hydrophilic lenses.
That was in hydrophilic, basically.
Tavan, since we are on the topic, in 2002 we reported 26 opacified IOLs of a particular company called GDR, and it was a report. It was an FDA-approved hydrophilic lens, and it was called as MDR in India and GDR in the US. And I also created a video, and at that time David Apple was chairing that session, and it was called the Whitewash, the video, wherein I presented all these opacified IOLs, how it has been removed and all that. And we sent all these opacified IOLs to Shankar Nethralaya, and Dr. JB was the one who worked on that, and he found a lot of calcium deposits in this particular type of lens. It's an FDA-approved lens. It's an hydrophilic lens, and even now, a couple of lenses we are seeing occasionally. I don't want to mention the company here, but it is there. So we need to be more calm. This thing, it's more commonly seen with hydrophilic IOLs. So and
next.
And it's something to do with the blood aqueous barrier damage also. Patients who got pseudo exfoliation, patients who got diabetes, and all these patients are likely to, apart from other factors in the lens. Only thing is, only one clear message is that if you have an opacified lens, if you have a doubt, please do not yag these patients. If you are going to yag them, you're going to be in trouble while exchanging these lenses.
So what do you think, hydrophobic lenses are easy to explant or remove, or hydrophilic lenses? What is your this thing as
hydrophilic lenses are easier to implant because the fibrosis around the capsule does not take place, and easily you can open it up. Even after 3 months, 6 months, you can open up the capsule if you use a good cohesive viscoelastic. You can open it up very nicely and you can explant it. But the hydrophobic, the problem is, especially the Acrysoft lenses, there is a bio addition between the capsule and the lens. And that is the biggest problem in opening these lenses up. And many times you might have to cut the haptic and remove only the optic. And because if you try to remove the haptic, the whole capsule will start coming up, the whole zonules will start coming out. So you just cut the haptic and leave the haptic there and remove the optic alone. So hydrophobic is more difficult to remove. But once you bring it in the anterior chamber, it doesn't make a difference. But from the capsular bag, it's difficult. Yeah.
So what I do, a small thing I do is that I do.
Excuse me, Purendra, we are running out of time. Our session is still.
Yeah, sir. Sir, one small trick I wanted to share with you that I do hydro dissection of the IOL.
You're ready, and please have your video ready and start.
Yes, sir. I will share my screen. Thank you. मिनिमाइज कर देना उसको। Thank you, Dr. Bharti. Can you see my slides over here? Can you see the slide?
Yes.
Thank you, Dr. Bharti. And I really appreciate, even in the COVID times, you have managed to do the Delhi Film Festival. All my good wishes. I will be sharing my experience of doing a secondary IOL implantation, and very nicely presented this videos of So there are various options available for secondary IOL. We all know AC IOL can be done, iris fixated IOL. One of our speakers over here will be sharing PC IOL, possibly in sulcus, or scleral fixated IOL, sutured IOL, glued IOL, glueless IOL, with various modification, Yamane technique, which is very popular nowadays. There are definitive advantages and disadvantages of each technique. The choice of technique will largely depend on surgeon's comfort. All these investigations, thorough examination, pre-operative evaluation has to be done before taking the patient for the secondary IOL implantation. So I will be sharing my first video, wherein this is an 8-year-old male patient who had a corneal tear repair done in the past, and the lens matter was removed, and the patient has been taken up for the secondary IOL implantation. There are a lot of posterior synechnias, as you can see, and the repaired corneal tear with partly removed sutures which are there, and because it was a large tear, so we have not removed the sutures completely. We are taking this patient for the surgery after 2 months of the previous surgery. The adhesions are being removed with the micro instruments, micro scissor, micro forceps. As you can see here, we are releasing the adhesions, and then because the pupil is small, so we are using 4 iris hooks for the better visualization, and with the small incision, paracentesis incision, we are making an opening in the OPHTHALMIC posterior capsule, which is in fact anterior and posterior capsule complex, and a 3-piece IOL is implanted or injected in the sulcus, and the haptic is then trailing haptic is placed back, and this is how the lens, a 3-piece lens with sutureless technique, we can inject and implant the lens, and the loose sutures are removed. Another case of similar type, post corneal tear repair. Then we make two paracentesis opening, and this is the anterior capsule opening present there. And throughout the procedure, we have to keep the chamber filled well with viscoelastic material. And with the help of retractor, we enlarge the opening of the capsule, as you can see here. So retractor with the setting of the first, the cutting is done later, and then as you can see here, central opening is created, and that comes to us very handy in and in a controlled way we can make a opening in the posterior capsule, anterior posterior capsule, as you can see here, and everything is controlled, and we have not use any AC maintainer. One can use AC maintainer for better control if they are not comfortable with the irrigation system. Another case, as a log standing aphakia, and the pupil is updrawn, is a badly managed aphakia. In the past 15-20 years back, the patient was operated upon. So we are making an opening, enlarging the opening of the iris, and with the help of cutter, we are making an opening in the central opening is created in the capsule remnant. So this way, a central round opening is created, and a sulcus is separated, is developed, as you can see here, with the help of Sinskey Hook iris repositors all around 360-degree. Sulcus is created, and the horns of the iris or the free end of the iris is separated so that the lens could be dialed inside. So this is a bit of more dissection is required in, but definitely by doing this, we save the problems or complications or issues related to scleral fixated IOL or glued IOL which are there. So now coming to the another technique, that is a modified Yamane technique when the posterior capsule is absent. Again, you can see there is no PC and post corneal tear repair. No, this is a post-traumatic case. This is a Yamane technique. There is no PC here. And the important thing is that both the incisions, both the haptic should be 180-degree apart. AC maintainer is being fixed, and we have to go 1 to 1.5 millimeter away from the limbus. So the entry of the forceps should be like that. With the help of cutter, we are removing all the vitreous from the anterior chamber. And as you can see here, then a 2.8 millimeter incision is made. A 27 gauge needle is passed, and same needle acts as a support for the IOL to go behind in the vitreous cavity. So we are supporting the lens, we are preventing the lens to go behind, and with the help of micro forceps, we are tucking the haptic into the forceps, into the 27 gauge needle. As you can see here, it comes out, and a special cautery, we make a flange at the tip of the haptic. This is a special cautery, heat cautery, and this flange should not be too big, neither it should be too less. If it is too big, it will come out of the conjunctiva. Then the trailing haptic is pushed inside, and with the bimanual technique, the haptic is pushed in the 27 gauge needle, hollow needle, and it is pulled out. The technique is simple, easy, and it takes less time and the IUL remains steady. The important thing is that we should keep both the haptics 180-degree apart for the centration of the IUL, and the two entry point or the point of fixation of the haptic should be equally apart from the limbus, which is around 1.5 millimeter. So these two things are very, very important to remember for the decentration of the IUL and for the prevention of the eccentricity of the IUL or for the undue astigmatism. Last case, which is especially a case with no iris over here, as you can see, post-traumatic. Some 15 years back, this patient was operated upon. Other eye, when he got operated, he wanted some solution for this eye also. So we have made a 9 millimeter, 9.5 millimeter opening here, scleral tunnel opening, and in a vertical manner, this lens, which is the iris diaphragm kind of a lens, which has to be fixated to the sclera. So this lens is pushed behind, and 1.5 millimeter away, the lens haptic is sutured. Earlier cases, we have it has been reported that they cause glaucoma, but in my cases, we have done almost 8 or 9 cases by now with this kind of lens, and we have not come across with the development of secondary glaucoma, maybe because our placement of the lens is behind the angle of the anterior chamber. This is how this reduces the glare and phenomena to the patient, and the quality of vision is very good. Only thing is that dissection is more, or 9.5 millimeter tunnel has to be created. This is the patient here, and uncorrected visual acuity was 636, which corrects to 6/9. To conclude, immediate and long-term success of procedure depends on the case selection, meticulous surgical planning, optimal surgical technique, and above all, surgeon's experience of particular technique. This is a clip of a video of a purple bird, which I have taken from my garden. And you can see the surgery should be such, all these cases, that without damaging the surrounding structure, the bird is taking the nectar, the good part of the whatever they want to do, the birds are taking the nectar, and without damaging or destroying or disturbing the flower. So this is how our surgery should be. And with this, I'll say thank you for giving me this opportunity. Thanks a lot, sir.
That was incredible stuff, Purendra. Very nice.
Thank you.
Yeah, I'll just make one quick comment, because the Yamane technique, what I saw you is you're putting the needle straight. So what you have to do is probably put a 27 or a 26 gauge needle in a curved manner, so that it will create a tunnel in the sclera.
No, we do it with that only. This was my first case. So now we do 1 millimeter. We make a incision, the 0.1 millimeter parallel to it, parallel to the limbus. So we follow that track, and then we pierce inside. And then we pierce inside 1.5 millimeter. This is how we do.
I must compliment Purendra for your wonderful videos as ever. And
Thank
you're
you.
part of the Delhi Film Festival always for last 4 editions, and this is the 5th edition. Wonderful being, having a friend like you. Thanks.
Thank you, sir. Thank you, sir. Thank you, Dr. Mohan.
Yeah.
Thank you very much.
Next.
Yeah, thank you. Shall I go? I'm the next, no?
Yeah.
Thank you.
You are the boss.
You are the boss. Able to see my video, my slides? Able to see my slides? Is my slides visible?
Yes.
Okay. I'm just going to show you a couple of cases wherein the glue magic in malpositioned IOLs. As you know, this is one of the most important advancements, I would say, when you have a dislocated IOL. Only thing is it has to be a multi-piece lenses. I'll just show you the case one, 70-year-old male, history of phacofoldable 15 years back, 6'9" vision, history of blunt trauma, and he was complaining of oscillopsia for 6 months. And now you know how oscillopsia is very, very troublesome to the patient as well. And pseudo-exfoliation was also, you can see that this patient had a multi-piece lens, and because of the blunt trauma, and he had developed a pseudophacodonosis, which was creating oscillopsia and also decreased vision as well. You can see this lens is moving around in the posterior chamber. So what we did was, we thought we'll try to fix the same, being a multi-piece lens, and we fix the same lens. We put a pars plana infusion, and 0-180 degree, we took a scleral flap, and then we created the Gabor-Scherer tunnels. Then we put a sclerotomy, and then you can see here, this lens has to be completely stripped of the cortex and the capsule. I brought this lens up into the anterior chamber, and you can see that I'm removing the capsule and the cortical remnants which are there around the optic of the lens as well. And all by using only very, very small incisions. You can see I'm doing an anterior vitrectomy also, and with a cutter, all with very, very small micro incisions into the eye, and making sure that all the additions are completely removed. Then what is called the handshake technique, the tip of the haptic is brought out, and then you can see that the glued IOL is done in a routine way. And again, you can see the handshake technique, the trailing haptic, the other haptic is also brought out. And again, the key is to hold the tip of the haptic and bring it out and make sure that the is centering. The advantage of glued IOL is that you can tuck and untuck on one side, and the pseudophacodonosis, you can tighten and loosen it on one side, and the pseudophacodonosis is very, very less. Again, I'm making sure there's no vitreous in the anterior chamber. Ideally, I should have used a tricot, but in this case, the patient had a family history of glaucoma as well. I didn't want to use tricot. You can see that the air bubble is there, the pupil is round, and I put the glue, close the flap, close the conjunctiva, and you can see the post-operative period, how the patient is. 6'5" vision, but absolutely not even a micro movement of the lens. You can see that the pseudophacodonosis is completely disappeared, and you can see that absolutely the eye is very, very quiet. This is on day one post-operative, which is very, very good. So again, another patient who had a dislocated IOL referred to us, and the subluxated lenses, and you can see again a multi-piece lens. If you have a multi-piece lens, what you can do is, whether it's there in the posterior chamber or in the anterior chamber or in the vitreous cavity, the same lens can be glued, taken up and glued out, glued using these techniques of 0-180 degree flap. Again, I'm trying to bring this lens into the anterior chamber, making sure there's a good viscoelastic in the sense. You can use an ACM also, or you can use in this case an ACM probably would have been better. In this case, I used a viscoelastic here, and again stripping the lens of the capsular cortical remnants and trying to bring this lens up. And I'm putting an anterior chamber maintainer again to make sure that everything is under control, all through small incisions. I don't enlarge the incision at all, and try to bring this lens up. But I think again the key is to catch the tip of the haptic, otherwise the haptic will get caught in the sclerotomy and get it'll break and make the matters a little worse for you. And again, another patient, you can see again a dislocated lens or a subluxated lens because of the post-operative. I think the patient had intraoperatively zonal dialysis, and the patient we implanted the lens. Unfortunately, the lens decentered. Again, we put the scleral flaps 0-180 degree, and this patient had a PCR as well, and a zonal dialysis and a lot of other problems. So we thought we'll glue this lens because the lens is grossly decentered. Again, the same principles are applied. So the bringing it up, making sure the vitreous is removed, the capsule cortical remnants are completely removed, stripping of the lens of this because I don't want the capsule to get caught in the sclerotomy site as well, and catching the tip of the haptic, making sure that you have the handshake technique. And again, you can use the pars plana infusion or use an anterior chamber maintainer. The anterior chamber maintainer is probably better. Now Amar has developed what is called the TACM, the trocar anterior chamber maintainer, which is very, very useful, which gives you watertight incisions as well. This is a 1 month post-op, 3 months post-op. It's really a pristine lens, as if the lens is there in the primary sitting. Just to show you the case 4, 63-year-old male, drop in vision, 6 months duration, shuttlecock injury, dislocated IOL, back complex, history of pseudo exfoliation. You can see here how this lens is moving around. The problem is this lens cannot be glued. Why? Because it's a single piece Acrysoft lens. You can see the thick haptics, and the bag is also there. Because of pseudo exfoliation, because of injury, it got worse as well. You can see the pseudophacodinosis which is there. So what I did was, I did a Hoffman's pocket. So what is this Hoffman's pocket? Clear corneal incision, creation of scleral pockets, and then a proline suture is passed into the 27 gauge needle through a paracentesis. It passed through the conjunctival scleral pocket. Second arm is inserted through the paracentesis and docked to the 27 gauge needle as well. And both ends of suture are retrieved through the scleral pocket incision using a Sinskey hook and tied under the roof of the scleral pocket. I'll just show you the video. You can see the video is very, very simple, wherein you just create a groove with a crescent knife and then go back. Okay, you don't take scleral flaps, go back underneath in the periphery of the cornea, and then go back underneath the conjunctiva as well, and create a tunnel from anteriorly to posteriorly. Again, I'm putting an anterior chamber maintainer there, and passing that 27 gauge, the proline needle, the 9-0 proline needle, and the long needle, and passing the 26 gauge needle through the conjunctiva, and one part of the suture goes above the haptic, one below the haptic, through the capsular bag or outside the capsular. It doesn't matter. It is only the haptic which is very, very important to be fixed. And the same way you do it on the other side as well. So once you do that on one side, you just try to retrieve the suture through the pocket anteriorly. And you can see here, I'm doing it in this side. I'm going through with the 26 gauge needle, and then docking that needle with the proline suture, one underneath the haptic and one above the haptic. So one suture goes so that it locks the haptic into place into the sulcus area. So that is the advantage of this. Along with the capsular bag, it does it. So unlike the glued IOL, you don't have to strip the capsular bag. So you can do this with the suture and then retrieve the suture and then put the knot and put the suture and push the knot inside the pocket as well. So this is another important thing which you're seeing. All the cases were managed ab interno with a totally different approach. Small incisions were done. There's no extension, no need for IOL exchange or anything like that. The same lens can be completely fixed, whether it is there in the it's decentered or subluxated, or it's in the vitreous cavity also. These lenses can be brought up. Only thing is, it has to be a multi-piece lens for a glued IOL. A single-piece lens, you need to do a scleral fixation. All the patients regained 6/6 vision. Thank you very much, Bharti. I always enjoy coming to Delhi Film Festival, and every time I really miss coming there. Thank you very much, Sudhank, Bhupesh, and the entire team. You've got a wonderful team, and I'm sure every year you have branded this DFF in such a great manner. I'm sure you'll reach greater heights in the future as well. Thank you very much.
Thanks for wonderful videos and explaining the technique so well that everybody could understand them. Any questions? So I will now invite Dr. Chauhan to present his video, and start it, please. Yeah.
Thank you very much, Dr. Bharti and Dr. Bhupesh, for inviting me. And since my topic is curvilinear capsular axis in different types of cataract, because we feel that there are at least 40 students in my department, and there are around 100,000 students maybe watching this. And this is a very basic topic because most of these people are wary of CCC. So if this is, I am doing some, I'm planning to show them that it is not very difficult. So I'm going for what type of different techniques can be applied to different types of cataract. The basic techniques are continuous curvilinear capsular axis, Kine-Opner technique, envelope technique, Japto technique now, and femtosecond technique. The advantage of CCC is that there is no risk of radial tears. They are resistant to tear. And in the bag, IOL is possible in almost every time. There is no menace of anterior capsular tag, and it is very elastic, and it is stretchable margin. And there is minimal trauma to the jonule during surgery. And the sulcus fixation of IOL is easier in case of PC rent. The disadvantage is that the visibility in mature and hypermature cataract is difficult unless strip and blue dye is used, and it is sometimes difficult in myotic people. The techniques are, you can use 26 gauge needle or forceps. You can use a small main tunnel or from the side port. But I have realized that since if you are doing CCC through the side port from the beginning, then it is very easy because the anterior chamber is very deep, and it is very easy to do CCC through the side port. People usually, the budding ophthalmologists, they start CCC from the main port, but AC keeps on collapsing, and then it becomes little difficult. You have to puncture in the center and extend toward the periphery. The capsular flap is torn using tearing and shearing, both forces, which are to be used centripetally. Each time the capsule is held near the leading edge, and it should end in circular manner. So if you can see this picture, if the anterior chamber is deep, so the anterior surface, anterior capsule is deep, then it is just like a skier is moving around, so he will not go to the periphery. But if in the second picture, if the anterior chamber is shallow, and the anterior chamber is shallow, then even if you try to bring the capsule axis centrally, it will try to go out. So the crux is that you have to keep the anterior chamber very deep with viscoelastic. If the interlenticular pressure is very high, you can use Helon GV, Helon 5, or if the it is closed chamber, even the SPMC is enough to make the AC deep. And you can make the AC deep by releasing the universal eye speculum, because sometimes the eye speculum is widely pulling that eyelids, and then it is causing the anterior chamber shallow. So the deep anterior chamber is the first and most important issue for doing a very good CCC. Another point is when the AC is shallow, then these jonules are relaxed. And if the AC is shallow, the jonules are taut. And if the AC is deep, the jonules are relaxed. So they are also pulling. So the moment the tear goes little periphery, they will pull the tear. In soft cataract or in grade 1 cataract, CCC should be slightly smaller, because what happens, the capsule is elastic in young and soft cataract, and when you are trying to aim a 4 millimeter CCC, it turns out to be 5 to 6 millimeter. And when you start a little larger from the beginning, it may extend into the periphery. And in a very good red glow, actually there is no need to put any trip and blue dye also. In immature grade 2 and 3, it is very easy, but you have to use the trip and blue dye because there is no good red glow. And whether you use cystotome or capsule axis, equally they are good. And in intumescent cataract, where the interlenticular pressure is very high, you need to use the side port, and you need to use the Helon GV or Helon 5. You have to make the AC deep, as I already told you, and start with the smaller and increase slowly. Or you can do a double spiral technique also. You have to debulk the cortex, which can be done to decrease the interlenticular pressure. This is one of the surgery I'm showing you. Okay, so like it is intumescent. You can see the fluid coming out of the bag, and then I'm trying to, because this was the first puncture in the center, and the milky fluid has come out. Some of the interlenticular pressure has gone down, and now we have to make a small spiral. So I say it a double spiral technique or double CC technique, so that what happens once you catch and make it a small CCC, so that whatever, because there are different pockets in the intumescent cataract, and when you, all the fluid may not come out simultaneously. So you have to tap or you have to debulk, then only some of the pockets fluid will come out. So you can see different pockets here. These are the pockets of the fluids in the different parts. So they are not coming. So once I had made a small CCC, and then I am doing debulking of the anterior cortex so that whatever fluid is there in different pockets, that will also come out and the interventricular pressure will go down. So it become easier because the antechamber is deep and you are able to do everything. And now you are going to put some viscoelastic to make this AC deep again, because we have to increase the size of the CCC. It is a small CCC to prevent the Argentinian flag sign, which is very common in intumescent cataract and hypermature cataract. So now with the help of this micro forceps, a cut was given, and then again a small, this CCC had been increased. So we are trying to increase the CCC. Keeping the anterior chamber deep makes the things very easy. The moment the anterior chamber becomes shallow, it will go toward the periphery. But if the anterior chamber is deep and it is a closed chamber, then you can easily play with CCC and it is not very difficult. Sometimes you enjoy manipulating the capsule axis with the help of forceps. Even now, this appears to be around 4 millimeter this thing CCC, and I realize that it is grade 3 to grade 4 cataract. So it will be a little difficult because I cannot go to the periphery. So I use the micro forceps, micro incision scissor to cut, give again a small cut, and again started to rotate the flap in the opposite direction to make little larger CCC. So I wanted to show in different types of cataract, but then I realized that since it will take more time, at least every CCC will be of 1 to 2 minutes. So it becomes 4, 5 CCC. So in this single surgery, you can see different steps. So in hypermature and Morgaginian cataract, in milky hypermature, you have to stain with the tryptophan blue under air so that it is easily stained, and keep AC deep with the hyperviscoelastic substance like Hilon GV or Hilon 5, and use double spiral technique. This was a double CCC, but double spiral, you start with the small CCC and then you keep on increasing the spiral. And you have to puncture the center and wait for the milky fluid to escape. And late intraocular pressure fall, and then you can proceed. And forceps are usually preferable. In cases of fibrous capsule, you can use the can opener technique because the CCC will be little difficult. And the disadvantage is sometimes the because the tear may be there, radial tear may be there, so sometimes the IOL may not be in the bag. So this was something to give insight of the CCC. Thank you very much.
Very nice, Chauhan. Very nice. Fantastic.
Thank you, Dr. Chauhan, for a wonderful video, especially the CCC enlargement from 2 millimeter to 6 millimeter.
Sir.
That was amazing. That was amazing. That is wonderful.
Very nice. Very controlled surgery. And it's a basic talk, but a very useful talk.
Thank you, sir.
Very nice.
The only thing I want to add here is that because in intumescent, especially the type 1 cataracts, since I've done a lot of work on this puncturexis, there is a pressure underneath the anterior capsule. The nucleus is bulky. There's a pressure in front of the posterior capsule also. And also there is a positive vitreous pressure. There are 4 components. So all the 4 components, if you put a needle and you take care of the component number 1 only, the other 3 components are still there. So still there is a possibility of Argentina flag sign. Second thing I want to be slightly differ with you is that if I have a small rexus, I'll go ahead with the phaco. And then probably the end of the phaco or before putting the IOL, I'll enlarge the rexus. Because if we try to enlarge the rexus, sometimes can still go to the periphery. And unless it's very small, I try to enlarge and do a spiraling rexus. Otherwise, what you have done is good, but I will not, if it's about 4 millimeter, I will go and do the phacoemulsification and then probably enlarge the rexus later. That's my point of view. Sudhank, what's your take on that?
Yeah, absolutely. You are right, because there is always a risk when you puncture it with a needle. Whatever smallest you can do, sometimes still it goes out. and causes the Argentinian flag sign.
Right,
So
sir, right.
one has to be careful, and like puncture access, or I sometimes do a retractor access, or the needle capsulotomy, needle rex, RP does. So all these are, they are measures to prevent Argentinian flag sign. Sometimes even putting a needle on the top, sometimes it causes, it's something beyond your
Control.
Anybody's control. It is beyond
beyond
any.
your control. Absolutely.
Absolutely. Sometimes it happens because of the high, very, very high intralenticular pressure.
Yes.
Very high intralenticular pressure.
Mostly that is the reason in type 1. And because when you try to enlarge that area where you have enlarged, that you're giving a nick there, that is a weak point there. Please understand, that can extend, go back.
Actually, the nick has to be very small. If the
I know,
nick is slightly large, it will go out.
Now, one thing is that we have to make it small. Second thing, I make it curvilinear. Means I immediately make it in a circular manner so that it doesn't go to the periphery immediately. Thirdly, what I do is I remove some fluid, the milky fluid which is there in the lens bag, and I remove it through the side port through very small needle. So through very small cannula. So if you aspirate it in a controlled manner, release the pressure from the lens, and then you push its viscoelastic in the anterior chamber, and then you can make a small, like Dr. Mohan Rajan has said, 4 millimeter axis. You aim for 4 millimeter axis, and then you can enlarge it before or after putting the lens inside the bag.
Actually, I used to do that, but since I found that if you are not done small CCC, then it is also difficult to aspirate that milky fluid. Sometimes if you give only nick and try to aspirate that milky fluid, then also that nick will extend.
It can extend. But all these things are dangerous.
Absolutely.
Absolutely.
Last week I had a case wherein by mistake the air bubble was given along with the viscoelastic. I just want to tell everybody. And when I've injected the visco, the air bubble went and hit the anterior capsule, and I had an Argentina flag sign and intermittent cataract. So the air bubble, too much of viscoelastic is also a problem. So we can open up the anterior capsule because there's a lot of pressure from beneath. So that is a problem. So the air bubble actually opened up the anterior capsule, and I got a fantastic video, and probably one of the conferences I can show it to you.
It's always better to have a very high viscosity viscoelastic like a Helon or something of that sort, because without increasing the intraocular pressure or anterior chamber pressure, it keeps the anterior capsule concave and down as compared to the HPMC or whatever you are using, because it tends to give way sometimes, and Argentinian flag sign is more common in all those cases. But in any case, this is a very challenging situation, and every surgeon has his own story to tell about the Argentinian flag sign. There are so many.
Yeah.
So I think if Dr. Suresh Pandey has joined, then I would like him to present a video of Dr. Vidushi Sharma. If he has not, then probably I'll share a screen and show my video.
Sudhankar, if you don't mind, kindly excuse me. I have to.
I can understand, Mohan. Thank you very much.
I'm quite sick actually. Yeah.
Despite your,
Please take care.
I'm thankful to you.
Thank you very much.
Please take care and take care. Wonderful. Thank you.
So, Dr. Bharti, your Delhi Film Festival has become just like Dubai Festival. So, I'm waiting to join it. I have been attending all these. This is the 5th film festival. So I was telling that we are having a Delhi Film Festival. So my family was asking which film festival you are talking about. So I had to share with them also that you also watch them.
Okay. So now I'll share my screen, and this will be my, okay. Where is that? Okay. Here we are. Share screen, and then share. Can you see it now?
Yes, sir.
Yeah. So I'll start my video and what happened?
It's at the bottom, I suppose.
Where?
Right side, center. Yes, this is.
Okay. So you already have seen two videos of Hoffman pockets, but this is a subluxated cataract where I wanted to create Hoffman pockets as a primary. It's not a operated case or something. It's a primary Hoffman pockets for the benefit of all the uh, participants, these residents, if they are watching, so that we understand if you are doing a Hoffman pockets as a primary procedure, how to go ahead. And the beauty of Hoffman pockets is that you don't need to create a conjunctival flap, you don't need to create a scleral flap. They are automatically created. The only thing you need to be cautious about is that you have to have a half thickness depth of the sclera and go ahead with the present. It should be a very sharp present so that there's no problem. And then you make two ports and use these ports to dilate the pupil and anesthetize the iris, because in majority of all these cases there is a possibility that anesthesia of the iris is not so good. And as you can see, this is a subluxated kind of cataract where nothing else would work. I could not have done anything to preserve the bag in this particular case. So I am doing a lensectomy with the vitrectomy probe, and I'll remove the total lens. This is a child, so that we can do a scleral fixation of the IOL in all these cases comfortably for a long time. They will have a very good vision. Pass the AUM5 suture straight needle. You need to have this AUM5 suture with a straight needle on both sides. And there's a railroad technique by which you can pass it at 2 points in both the sides with the help of a 26 gauge needle. And then you can, have, so these are the two needles passed from one side to another. And at the distance, which is about 1.5 to 2 millimeter, where in the phakic eye, the pars plana is there. And then you can make a main port, because here we are trying
इसमें
to.
होगा डैशबोर्ड पे, उसमें क्या क्या है, पेपर है, अपन ने और भी कुछ चीजें भेजी थी.
You need to mute yourself when you're talking to people.
Yeah.
So anyway, the main port is made, which is again, and then pass the sutures through the fenestrations in this, these SFIOLs which are there. I don't want to put anything except these SFIOLs in these particular cases. I think these are best. The size and everything is most or say least traumatic. In all these cases, the surgery is much more comfortable, and the long-term results are very good. I and Purendra have done a lot of scleral fixation IOL ICs in EIUS in our early days, something like 20 years ago. And these cases are still doing wonderfully well, though quite a lot of them were in the early years of their life, and quite a lot of them are now in the age group of 30 or 40, and they're doing extremely well. And at that point in time, we were doing, majority of them are the PMMA lenses. Now, I also feel that PMMA lenses designing is much better. Here, you just pull out the suture from the section, and you don't need to do anything. Just pull out the suture. You are already beneath the flap, and just tie them together. Cut one end to make it a little smaller, and then tie them together. This surgery will hardly take, about 20 minutes as compared to any other surgery, which is going to take a lot more. So these are, because we are not doing a lot of suturing here, only the fixation for the IOL. Those sutures are to be tied. Beyond that, not much of tying or suturing is required. These conjunctival flaps, they go in place with ease, and without any suturing you can just leave them alone. So the scleral flap as well as the conjunctival flap, and then you can go ahead and do the viscoaspiration and do the vitrectomy from behind the lens, so that there is no vitreous coming to this section, and that everything is clear. You can do all the other maneuvers to make sure that you don't have any vitreous in front and behind the lens or in the sections. And once you have done that, it's a wonderful result which you get the next day. Hardly any I would say a surgical clues after some time. Thank you very much.
Thank you, Dr. Bharti, for showing us an extremely difficult case and managing so beautifully. It was a dislocated lens which was floating on the anterior vitreous. In this particular case, you have shown the anterior approach of doing a lensectomy and how to support it from behind so that the lens matter should not go into the vitreous cavity. I think that has been very nicely depicted, and creating Hoffman pocket before you enter into the anterior chamber, maintaining the intraocular pressure, that makes it easy to create a Hoffman pocket. All these things beautifully depicted, and as if it was a copybook type of a case presentation, what I would say. And rightly said that PMMA lenses are really wonderful lenses. Only thing is you require a larger section. But if managed properly, with these cases, they last very long and without any complications. They really don't come with the problems associated with such cases, and very nicely maintained. The only thing which you have, the good thing which you have highlighted is the removal of vitreous from around the lens, all around the lens. If that is managed properly, I think that is the crux or the key point to remember in all these cases of secondary IOL. Thank you. Thank you, sir.
Thank you, Dr. Purendra. And before I end this session, I will again ask whether Dr. Suresh or Dr. Vidushi are here to present their video. If they are not, then I would request the last video of our sponsors from the support.
So we have done some, I think, thousands of cases, more than thousands of cases of this SFIOL by now. I have been doing this technique for last since 1994.
Yes.
In 1994, I have been doing this technique in all age groups, and all these patients are doing really well. Hardly any complications related to the retina or to the decentration of lens or to tilting of IOL or related to the sutures. Very, very rare. In early days, we used to have these problems. Now, I think we have come across with all these things, all these issues.
Absolutely. Because we had those ICs where we showed our old videos, 20 years ago, we showed the SFIOL, different techniques of SFIOL. And I and Purendra, we did deliberately all those cases. We did deliberately all those cases. We took as a challenge and started doing more and more SFIOLs in our early years, where people were putting ACIOLs. We never put ACIOL. We never did that ACIOL thing, and always wanted to do a SFIOL from the beginning. So that was another thing which we started, and we never did ACIOLs in all these cases.
We still see cases being done where PCIOL is placed in anterior chamber.
Oh, yes.
routine. With that also we see is still I am seeing, say last week only I have seen one case. So I have to explant it and I exchanged it with the another, with the PCI. And that is the thing which is being, I think newer generation, all these people, PCIOL is the best way of managing any cataract surgery, what I feel is. Thank you.
Okay, thanks very much. So have Dr. Suresh Pandey joined us, or Dr. Bhupesh, are you there? If we have a video from the sponsors, I think this video is what we want to show for 2 minutes. So I would like to conclude this meeting today by thanking my co-participants, Dr. Chauhan and Dr.
Thank you, sir.
Surendra Bhasin. Their support has been, tremendous. Also, Dr. Mohan Rajan for joining despite the fact that he was unwell, and then Dr. Sutanshu for this, participating in this session. I must thank all the moderators and panelists of all the sessions which were done before us, and also our sponsors like KLB, Vartis, Neomedics, and Allergan today, and Cipla tomorrow. Cipla has been great help for, and we thank them from bottom of our heart for giving us, supporting us in this COVID times. So thank you very much. Thank you. And also thanks to Sunil for conducting this meeting in a flawless manner. Their support is amazing. They're very good in giving us all the links, and also without break, a wonderful meeting. Thank you all. Thank you, Puren. Thank you, Dr. Chauhan. Thank you,
Thank you,
sir.
sir. Thank you.
Thank you.